All right, so any questions from the last time that we met? Everyone feels good on the fundamentals of antibiotics? Yes, that's the yes, I'm okay on the fundamentals of antibiotics music. We're gonna now move in to the drugs. I'm gonna try to get through all of this today, start some of the dermatology stuff just so we kind of stay on track based on the schedule. Obviously, if you have questions, stop me and ask. But have you covered any antibiotics anywhere else, like in your med class or anywhere? You guys could have like an entire like dissertation on antibiotics, and you still like come into this class, ask you that question, and be like, a little bit. That's okay. I get it. I get students. Anyway, when we're classifying antibiotics, one of the best ways you can break them down into various categories is based on the mechanism of action. You're going to find that with a lot of drugs is that you'll be able to group them up based on mechanism, right? And so when I ask a test question, generally the main form of that question is going to be asking either a level 1 or 2 type question where I say, what's the mechanism of action, or which of the following drugs does this? And you're going to have 5 different drug choices, right? I'm not going to put the categories of drugs, I'm going to put the actual drug choices themselves. So your job is to try to link back those drugs back into their specific categories, right? So for instance, if I write penicillin on as an answer choice, you know that fits into which category of drugs. You'd say penicillin, right? You'll say, we're going to say penicillins, right? And so you can say, okay, well, I know penicillins are going to be beta-lactam drugs, right? So that's another step up. I know beta-lactam drugs fit into drugs that work against the cell wall, right? So that's going to be kind of the top of the hierarchy there. And then based on that, then you know a lot of stuff about that drug already based on mechanism of action, monitoring, side effects, etc., right? I will tell you that when you're trying to go through, you can't memorize every single detail out there, and I would not want you to do that. If I spend like 10 minutes talking about something, it's probably a good thing to know, right? If I kind of gloss over something, I'm probably less likely to really drill down and get into the nitty-gritty of that for the test. If you just know the broad strokes of things, it's probably like 80% of the test right there, right? It's when the extra 20% at the end there's going to be more of those nitty-gritty details. So if you can learn the things of broad strokes, like I know everything in general about penicillins, and then drill down further, but what's the difference between piperacillin tazobactam versus amoxicillin clavulanic acid, right? Those are the details that are going to help to get you that final bit of the way there, okay? So anyway, let's get into the drugs here. First off, we're talking about beta-lactams, okay? Beta-lactams are going to be our first set of drugs that work on the cell wall. You're going to find that we call these beta-lactams based on this ring they have right here, this kind of 4-point ring they have. And all the beta-lactams we're going to talk about today, penicillins, cephalosporins, carbapenems, they all fit into the same category. The big differences between them are going to be these little side chains off of here, right? So when you see R, that just means, you know, it's kind of a placeholder for different side chains. That's the only difference between these drugs here, right? So again, they all have the same mechanism of action, so you don't have to worry about that. So if you see penicillin, cephalosporin, carbapenem, you always know they have the same mechanism of action, okay? That mechanism is that they're going to be working to disrupt the cell wall of the bacteria, okay? They do that by kind of looking like 2D alanines, and what you're going to find with the cell wall of the bacteria is that they have these crosslinks that form between the different layers, and those crosslinks provide that structural stability. If you can disrupt that, then you can disrupt the cell wall integrity. That's going to then open up the cell wall, and then just like if I put a hole in you, you probably have a lot of things leaking out. Same thing with the bacteria, you probably die, so the bacteria does. I'm not going to do that to you, but I mean, I feel like your head's probably leaking out a lot of information. But anyway, so by doing that, there's going to be a specific protein that the penicillins and all the beta-lactams are going to bind to. And this one's called penicillin binding protein. So it's really easy to remember. Penicillin binding protein binds to penicillin, right? That's how we discovered it, basically. And so by covalently binding to that, right, kind of forming this nice permanent bond there, you disrupt that penicillin binding protein. Cannot then make those crosslinks between the cell wall, okay? So again, you're inactivating the enzyme. Now it cannot form those nice crosslinks. You can see a picture here of these crosslinks that form between the different layers, and that's disrupted, right? When you see here penicillin coming in, you're going to open up a big hole in that bacteria. It's going to lyse out its contents, and then the bacteria is dead, okay? So remember we talked about things being bacteriostatic versus bactericidal. Which one do you think this falls into? Bactericidal, right? If you open a big hole in the bacteria, it's probably going to kill it, right? Again, we'll show you some examples of bacteriostatic drugs a little bit later on, but typically when you disrupt the cell wall like this, they're bactericidal drugs, okay? So starting off, we're going to go with the OG penicillin G, right? I don't know where the G comes from, but so penicillin G, some of you might have this growing in your refrigerators at home right now, right? Maybe. college students, you know, sometimes hygiene and personal care goes out the window, especially for your fridge. Anywho, so when I go through these antibiotics, I'm going to use this stoplight metaphor. And again, this is not the perfect metaphor, and there's not going to be a perfect metaphor, but I think this kind of helps with the broad strokes of coverage, right? So I will tell you, as far as coverage goes for these antibiotics, typically I'm looking for broad stroke sort of things, right? So when I say gram-positive coverage, I'm kind of talking about gram-positive in general, right? And when I say gram-positive, that just means the aerobes, okay? The oxygen-needing ones. If I say gram-negative, I'm just referring to gram-negative aerobes. If I say anaerobes, we'll talk about specific drugs that cover anaerobes. That'll be sort of a different category. When I say atypicals, we'll talk about drugs that cover specifically atypicals, okay? There are certain bacteria that I do definitely want you to be cognizant of, and when you hear these bacteria, you should definitely know whether or not that antibiotic has coverage for it. 3 big ones: Pseudomonas, MRSA, anyone know the third one? Clostridium difficile, right? So C. diff. Those are 3 big ones. So again, MRSA is what type of bacteria? Gram-positive or negative? It's gram-positive one, good. So again, you're going to start to see these associations between, okay, this one's a really good gram-positive killer. Oh, look, it also has MRSA coverage. That makes sense. Pseudomonas, what is that? Gram-negative, right? So you're going to see some of these bigger, and again, when I talk about antibiotics, I talk about them in the sense of firearms, not because I'm a gun nut by any means, but I talk about, you know, basically how broad of a spectrum they have, how big of a ability they're going to have to kill off these bacteria. So, you know, penicillin is very specific. It's going to be like a little pea shooter, right? Versus with some of our other drugs, something like, you know, carbapenem, like meropenem, it's like a nuclear bomb, right? It's going to be able to kill off pretty much everything. So I'm going to use that kind of mantra. Again, I don't advocate violence, but again, I do advocate violence against these bacteria. We want to get rid of them, right? So anyway, so I think it'll hold. Right, so those are, and C. diff, what type of bacteria is that? And it's an anaerobe, right? So we'll talk about anaerobic coverage, but again, there's specific drugs that will cover that. All right. So again, penicillin G, this is the first one that we had that revolutionized the treatment of infectious disease. You know, it's got okay gram-positive coverage, right? But one of the big things you're going to note with these early penicillins, they do not cover staph, okay? So that means if you had a skin infection and you're really worried about something like a staph infection there, you're going to find that penicillin G is just not really going to cover it, right? We'll talk about some ones later on that actually does pick up that staph coverage at that point. Has a little bit of anaerobic activity. It does not cover Bacteroides fragilis, which we've mentioned is one of those kind of gut anaerobes that is of concern if you're thinking about things like, you know, perforated gut or something like that. So it doesn't cover that, but we'll cover some anaerobes. However, you're going to find that penicillin G is typically very specific for certain coverages. So for instance, you know, if you get syphilis, I don't advocate that, but if you do get syphilis, a shot of penicillin will do you just fine, right? Gas gangrene, meningococcus, these are things that penicillin G has got pretty good coverage for. So it's a very narrow spectrum sort of antibiotic, but it's the first one we had. Now, I'm not going to have you know dosing specifically, but I just want to get you at least some exposure to this. So when you see it, it kind of makes a little bit more sense to you when you see, you know, dosing regimens and things like that. Notice here, this one's not dosed in milligrams, it's dosed in units, right? Units is always one of those things you always want to write out, not just put U when you're writing prescriptions. But what do you notice about how frequently we're giving it? Every 4 hours. That's how many times a day? 6 times. I just doing the other day. It was just like, okay, every 4 hours, so 4 times a day. I was like, no, try it again. It's not 16 hours in a day. Right, so again, this is 6 times a day. So is that really convenient from a patient standpoint? No, it's not very at all, right? If I take something 6 times a day, they're waking up in the middle of the night to take it. But what does that tell you about the way that it kills those bacteria? Time-dependent killer, right? So if I'm having to give it very frequently, I need to make sure those levels stay above the MIC in order to kill off those bacteria. In fact, in some cases, there's some cases where we have certain types of endocarditis we'll be treating, like say like an IV drug abuser or something like that with penicillin G. We'll give it via 24-hour continuous infusion. It's just running constantly to stay above that MIC to make sure we get consistent microbacterial kill there, right? And again, obviously, anaphylaxis is going to be one of the big things you're worried about with any drug that you're going to be administering. So again, what are signs of anaphylaxis?
Trouble breathing.
Trouble breathing. You're going to feel like the throat's closing up. What else? Swelling, redness, itchiness, rash, right? Hypotension is another big one, right? So if your blood pressure start to drop after you give an antibiotic, that's not the antibiotic, that's the allergic reaction they're having there, right? These are things you want to watch out for. We'll talk about penicillin allergies in just a few minutes here, but that's kind of one of those medical dogma things we're going to try to dispel there in a little bit. Now, there's several different forms of penicillin. Penicillin G itself is IV only. When you give it in the stomach, you realize it doesn't actually have any activity there because the stomach acids will just break it down. So instead, what we have are some other varieties of penicillin G that has the ability to stay stable in stomach acid. So for instance, penicillin V. potassium, or penicillin VK, right? K for potassium on the elemental chart there. That's going to be stable in the stomach acid. So if you ever see Pen VK, that is the oral form that patients can take at home. You know, there's, as I mentioned, penicillin G is going to be the IV form, and this is another kind of unique form called benzathine penicillin G, or bicillin. Oftentimes this is labeled as bicillin LA. Anyone know what LA stands for in regards to drugs? Long acting, absolutely right. So this is actually a really good one. What do you notice about the color of the drug here? Yeah, it's kind of white, milky, right? Typically you want your drugs to be clear because I'm going to be injecting something into the patient. Typically clear drugs kind of show you there's no like precipitates, there's no other kind of gunk in there or anything like that, right? Because again, you worry about things like big particles cause emboli and things like that. This is actually an IM only drug. So I can inject things and again, we put it in this nice oil sort of emulsion. It kind of looks like milk, but it's kind of nice fatty sort of emulsion. We'll put that into the muscle, and that will then slowly release the drug out over time. And so, for instance, like we use this a lot in the peds ER. Say, for instance, you come in with a child has strep pharyngitis, right? So we'll learn about this in ENT a little bit later on. The kid comes in with strep pharyngitis, their throat is super sore, they're not really wanting to take medication, they can't swallow very well. Sometimes we'll just give them a shot of penicillin G, and due to the long-acting nature of it, they just get a one-time dose. Yeah, it kind of hurts for a minute, but then they're good to go. They don't take any more medication for that specifically, okay? So there are some use cases where patients may not be able to tolerate oral medications. You need an alternative, right? And so that's when we're using what we call parenteral therapy. When I say parenteral, what does that mean? Yeah, kind of anything using a needle, basically, right? So IM, IV, sub-Q, anything like that we consider to be parenteral. In this case, we're using the IM route, okay? So it's nice because it has a nice kind of slow leaching sort of effect there. So yeah, penicillin G, very narrow spectrum for the most part, but then we said, well, that's okay, but let's see if we can get any kind of better sort of penicillins here. So now we move into what we call the Aminopenicillins, okay? So here we have two main drugs that fall into this category of ampicillin. Most frequently, you'll see this used in the inpatient side as an IV medication, and its counterpart, amoxicillin. This is PO only, and it's a very, very common antibiotic. You're going to see it used like water, especially over in like PDRs and things like that. A lot of amoxicillin gets used. Okay. Now, again, this still does not have any staph coverage, right? So it still lacks that coverage, but it can be good against some gram-positive cocci. Again, some anaerobic coverage, still not going to be able to get that Bacteroides fragilis, and we'll get some gram-negative anaerobes. Now, where we're going to use this is due to, again, it being very specific for coverage for certain bacteria. So, for instance, things like Enterococcus, things like Listeria, things like, a lot of upper respiratory tract infections, right? Now, have you covered any ENT stuff yet? Okay, when we get into ENT, we're going to find there's three big bugs that cause a lot of those infections. You're going to see, and you don't have to know this from my test, but specifically, you will later. But when you run into that, you're going to see strep pneumo, you're going to see H. flu, and Moraxella catarrhalis. Those are the three big ones for the upper respiratory tract infections. This actually has pretty good coverage against that, right? So if I had a patient who came in, if I say like an acute otitis media, I can give them amoxicillin, and that will treat that because, again, it's usually one of those three bugs. Again, not specific for this test, but we'll come back to that later on. But again, we're going to find that this has very specific coverage, not very broad yet, right? So, if you think about, penicillin G being kind of like one of those little derringers you see like in the Old West, this is like maybe going up to like a 9mm or something, right? A little bit better coverage, but it's still not great, right? So it's not going to be a huge amount of coverage you're going to see with that. All right, and again, these are still going to be time-dependent killers. They're still going to be bactericidal, just like any of the other penicillins are going to be, okay? So that has not changed. Now, some of the things you have to consider, anytime you have patients who are on anticoagulants, sometimes you're going to find things like antibiotics can actually make the patient more likely to bleed. In some cases, for instance, you have drugs like warfarin. So anyone familiar with the drug warfarin or Coumadin, ever heard of that? It's a blood thinner. Actually blocks the effects of vitamin K in the liver, so you can't make new clotting factors. We'll cover that in hematology later on, but just know that vitamin K, anyone know how we get vitamin K absorbed through the gut? What's really... The bacteria, absolutely, yes. So you need the bacteria to help to get vitamin K in a form where you can actually absorb it. Very important. Well, if I give antibiotics systemically, does it just affect the bacteria wherever I'm trying to treat it, say in the ears? It's going to affect everywhere, right? So if you disrupt the gut flora, this is where you're going to run into some issues here, right? So when you hear about things like taking birth control along with antibiotic courses, that's why, because you're disrupting those gut flora. If you take it with, if you worry about things like anticoagulants, this is the problem you're running into, is you're disrupting that gut flora. When you hear about things like C. diff taking hold, it's an opportunistic infection. That's because you disrupted the gut flora, okay? So that's why frequently a lot of people will say just take some probiotics. I don't know necessarily that's going to help 100% of the time, but may be somewhat useful in these cases. So that's why you see that. And again, in the case of things like birth control, right? So some people say, well, it's probably not clinically that relevant. And the problem is that normally estrogens, right? Estrogens will be sent out. Anyone know how it gets eliminated from the body? Actually, it's eliminated through the liver, right? So it gets eliminated through the liver, goes out through the bile, and then it will get spit into the GI tract. Well, that's not the end of the story for estrogen. It'll just poop out all that estrogen. What you're going to find is that the bacteria in the GI tract will actually help to kind of break it apart and reform new estrogen, right? So the liver gets conjugated to something else, makes it more soluble, gets into the GI tract. Bacteria then break that down, and then you can reabsorb that estrogen. That's what we call enterohepatic recirculation, where you're spitting out of the liver, comes back into the GI tract, spit it out of the liver. So that extends the half-life and keeps it around for longer. Well, if I get rid of those bacteria, I may not be able to recycle that estrogen as well. So estrogen levels drop down. Anyone familiar with oral contraceptives, what happens when your estrogen levels drop down because of that? You ovulate again, chances for pregnancy increase, right? Now, is it going to say that if you take amoxicillin along with your birth control and you have sex unprotected that you're going to get pregnant? No, right? But the chances may be increased, right? And again, is that something you want to play the chances game with? Typically, right? Don't want to gamble with those chances. So it's one of those things where it's like the clinical evidence probably isn't that strong to say like you absolutely have to use a backup form of contraception, but what are the risks of using backup forms of contraception? Almost zero. The risk of having a baby, yeah, the detriments there, if you're not ready for it, could be bad, right? So again, some of those things are going to be like, well, we don't always have the best evidence to show that this is absolutely necessary, but again, what are the downfalls of using extra contraception? Not really anything, right? Anyway, so again, that's one of the things you'll see frequently talked about with things like oral contraceptives. Obviously, the safest form is what? Abstinence. Everyone should practice that. My daughters will be practicing that as best as I can help. Anywho, so side effects, right? So side effects in general for the penicillins, you're going to find that, certainly can have a little bit of hepatic dysfunction, things like, ALT, AST increases, things like that. You don't really think about these as being super liver toxic, but there are things to monitor for, right? Obviously, things like Clostridium difficile infection as an opportunistic sort of bug popping in there due to disrupting that gut flora is a risk as well, so be careful with that. We'll talk about one drug in particular that is really nasty for causing C. diff, and so when I mention that, it's a good thing to know. Now, has anyone heard of Stevens-Johnson syndrome or toxic epidermal necrolysis? What is that? It's bad. It's a hypersensitivity, and to say a rash is definitely kind of underselling it a little bit there, right? So basically, the patient will develop these blisters all over. The skin will start to slough off, and if not caught early, can be quite deadly, right? So again, early aggressive treatment is really important. So we'll talk about different drugs that is a risk. Obviously, education is really important. So if you start to take this and they just see these rashes show up all over, they need to know that that's not just normal course of treatment. That's not just a normal thing. They should probably get that checked out, right? So again, especially if they're having blisters and things like that, that's not normal. They need to know that because again, otherwise they may think, well, I guess this is just how things are right now, and then they delay that return to medical treatment, and that can lead to significant morbidity and mortality, right? So be careful with that. Now, all the penicillins are going to be renally eliminated, which means you need to renally dose adjust them for patients with renal dysfunction, okay? So be careful with that. Make sure you're checking out those dosing ranges, and typically they do it based off that creatinine clearance. Remember we talked about that in Intro to Pharm? Hopefully I haven't repressed all of that, but you can get a creatinine clearance for your patients, and based on things like, okay, well, if it's above 100, yeah, you dose like the standard, right? But if it gets down, say, 60 to 90, here's how you dose it. Between 30 to 60, you dose it like this. Between 0 to 15, you dose it like this. Those are important considerations. You need to look those up. Otherwise, you could have levels that are going to be too high, and too high levels lead to toxicity, and we don't want that, right? Anyway, now, of course, if your patient has a history of being allergic to penicillin, obviously don't give them more penicillin. We'll talk about cross-reactivity a little bit later when we get to the cephalosporins, but just be careful with that. And obviously, any pre-existing hepatic dysfunction that could be worsened by these penicillins. Okay. All right. Again, look for the renal function as I mentioned. Yes, sir. Yeah. So that's usually specifically a concern with warfarin, right? So warfarin is something that blocks the activity of vitamin K being recycled within the liver. Basically, you can't produce new clotting factors without that vitamin K, right? So the thing that helps us to generate that vitamin K to absorb from the gut is going to be the bacteria there, right? The colonic bacteria actually help to prep that vitamin K so we can absorb it effectively. If I give an antibiotic and I wipe that out, those bacteria are gone, cannot produce that vitamin K. Now the levels of vitamin K have gone down. Now the warfarin's going to be working too well, and you see bleeding, right? The other things we may see like a thrombocytopenia, obviously that can also increase your bleeding risk, but typically you don't really see that frequently. Anyway, so again, as I mentioned, and when I say side effects for these drugs, again, I could say nausea and vomiting, unless it's something like really particular, like, yeah, every single patient's going to vomit. Like, I'm not going to really mention that. It's not really worth your time to sit there and think about, okay, this one has nausea and vomiting, this one has nausea and vomiting, this one has, all drugs can cause nausea and vomiting, right? If you look at the package insert for any drug, when drugs are on trial, right, and you're giving it to all these patients, any side effect they have, whether or not it's going to be actually related to the drug, gets listed, right? So again, if someone dies from getting, from a hemorrhagic stroke while they happen to be taking penicillin back in the clinical trials. Now, they did that way back in the day, but they had that. You'd have to say hemorrhagic stroke has been seen with this drug, even though you may not be able to link it back directly. Okay, so these are things where a lot of side effects are going to be relatively common. Just know that they happen with most everything, right? So nausea, vomiting. If I mention it specifically, for instance, chemotherapy, and I say there's strong nausea and vomiting associated with this, that's something to note there, right? But otherwise, just know that for everything. Again, diarrhea is going to be a very common thing as well. You're going to see with any of these antibiotics because, again, you're disrupting things like the normal gut flora, etc. Okay. Now, the question is, well, these bacteria, it'd be nice if we could use penicillins for everything, but we're going to find that a lot of bacteria tend to be resistant to the penicillins, right? And so there's several ways they can do this. They can do things like changing their penicillin binding protein to where the penicillin can't actually interact with it anymore. That's one way. The other thing I can actually do is generate this product called B-Lactamase. So beta-lactamase, if you had to guess what the function of that enzyme is, does what? Breaks down beta-lactams, absolutely. So if you cleave this ring right here, the drug does not work anymore. It cannot bind to that penicillin binding protein, right? So how do we get around that? Beta-lactamase inhibitor, right? Sometimes science is very straightforward in the naming convention of things. We give a beta-lactamase inhibitor, try to prevent that from occurring. So these are drugs that have no antibacterial activity themselves, but we will give them along with an antibiotic in order to kind of tie up that beta-lactamase, kind of inactivate it, and then the drugs themselves can then become more effective, okay? So again, these are augmenting the activities of the actual, the business end of the molecule, the actual drug you're giving to treat that bacterial infection. So 3 of them you're going to run into. Sulbactam. This one is given primarily with ampicillin, so you're going to get the drug called Unison, right? So it's a different, it gets a new brand name when you have a combination drug like that. You're going to find tazobactam. Is going to be found with a drug called piperacillin, which we'll talk about in a moment. That's called Zosyn, the very frequent broad-spectrum drug we're going to use a lot in the inpatient side of things, okay? And then you're going to find clavulanic acid or clavulanic, just 2 names for the same thing. That gets put with amoxicillin, and then you have augmentin. That's very, very common for the outpatient side of things. So when you send a home a patient for, ear infection, rhinosinusitis, things like that, you're going to find a lot of augmentin gets sent out with those patients, okay? So again, these are good drugs to be familiar with because the coverage actually changes pretty significantly when you add on a beta-lactamase inhibitor. So for instance, if I add an aminopenicillin plus a beta-lactamase inhibitor, so I either have augmentin, which is amoxicillin clavulanic acid, or have ampicillin plus sulbactam, all of a sudden their coverage changes greatly because now all these bacteria that were producing beta-lactamase, they're being inactivated, right? So now these drugs can work even better now. So for instance, now we have a lot better anaerobic coverage. So for instance, Bacteroides fragilis in the gut will now be covered by this, okay? So what you see here is the anaerobe. This is the first ones we have that actually have pretty good anaerobic coverage. And remember, where else do you find anaerobes besides just the gut? What else do we say? Kind of associated with the GI tract. Sometimes you may find it there, but not commonly. The mouth, right? Remember the mouth? Yeah, we talked about. That's included in the GI tract. But anyway, the mouth is another big one. So, for instance, these drugs tend to be the drug of choice for animal bites or people bites, as the case may be, right? Now, remember I was talking about how when you have an animal bite or something, you're not only worried about the anaerobes in the mouth, but you're also worried about the skin flora that was growing on the patient's skin in the first place, right? So this has pretty good coverage. The nice thing here as well, this now covers MSSA, right? And that stands for what? Methicillin sensitive Staph aureus, and so that actually has coverage for that now. So not only do you get the easy skin stuff that's growing on the patient, but now you also get the coverage for the anaerobes that was growing in that animal's mouth. Do you have a question?
Yeah. So this might be a dumb question, but methicillin, like we never end up learning about that.
That'll come up in a second. We don't use that drug anymore, though.
Yeah.
Yeah, so that's one of those like kind of historic points where like we just call it that, and that's just one of those things that gets carried on in perpetuity, even though we haven't used the drug probably in decades, right?
Should really be called like aminopenicillin sensitive.
Well, no, because remember the original aminopenicillins did not cover MSSA.
But now they do.
Once you add on a beta-lactamase, I will talk about in just a moment, and this is a good segue, the anti-staphylococcal penicillins. That will come up in a second, okay? So just Stay on the edge of your seat. Don't worry. We're going to get there. You guys are just chomping at the bit to get all these antibiotics. But anyway, right, so again, this is good anaerobic coverage. You're also going to find this is good for things like diabetic foot infections because, again, when you think about the foot being in a shoe all day long, there's a lot of anaerobes that are growing there, right? You know, you think about diabetics having the neuropathies, don't even feel that they're getting these infections that are developing. Like, these can be pretty nasty infections. This is good for that as well, right? Intra-abdominal infections we can use this for because we talked about the GI tract having a lot of gram-negatives, a lot of anaerobes. This is really good coverage here, right? And again, we'll use these for more resistant upper respiratory tract infections as well, which is why you're going to see this used quite frequently for things like resistant acute otitis media. You're going to see this for, you know, sinusitis, all these different things you're going to find it being used for pretty frequently.
Would this be good for like traveler's diarrhea?
We'll look at some other ones that have a little bit better coverage for traveler's diarrheas. You'll see some specific cases where we're going to use things like, you know, Bactrim for things like Shigella or Salmonella, things like that. So not as common, but again, if you're never not sure, you can look it up, right? So again, look up things like, you know, IDSA guidelines for traveler's diarrhea, or look up things like the Sanford Guide, which again is going to cover all of infectious disease. You can find out what the first line treatments are going to be recommended, what to do if they have an allergy to the first line treatment, etc. Right? Now, as I mentioned, we have the anti-staphylococcal penicillins. Now, again, these are going to be very narrow spectrum for the most part. You don't ever start off treatment with one of these anti-staphylococcal penicillins because their spectrum is so narrow. But these are the first drugs that we had that really covered MSSA. Methicillin being the first one that we have. But now we have nafcillin, we have oxacillin, and dicloxacillin. Okay, so very frequently what you may have happen is, say, for instance, you have a patient gets admitted, say they have, you know, cellulitis or something. You're worried about MRSA. You'll cover for that initially. Right, but what do we say you do when you get those cultures and sensitivities back? You de-escalate, right? So, for instance, a patient you're worried about MRSA, say you give a really big gun to that will treat that, they come back and it's MSSA and says, hey, it's sensitive to oxacillin. Well, now you need to de-escalate, right? So now you're going to be streamlining it down, and so I can give them something like oxacillin, treat that infection rather than having to give them something really broad spectrum. Okay, so that's usually the course of things, how they'll go. You'll start with something like this is very narrow. You want to start with things that are more broad and then narrow down later on once those cultures and sensitivities are back. Okay. So anyway, so again, we are finding MRSA rates going up though. So again, this has a very narrow utilization, only really when MSSA is actually cultured out and shows to be sensitive here. Again, same monitoring, same adverse reactions, same everything as the other penicillins here, same renal dose adjustment you have to watch out for. But again, these are just good for MSSA. Okay. Yes, ma'am.
So you said do not know the specific dosing, but do you know, you wanted to know if it's either IV, IM, or PO?
You know, I won't, unless I make like special note of it. So for instance, like we talked about the bicillin, like it's a good IM medication. It comes in that emulsion, like, and we talked about that. That's something I would, you know, it's good to get that exposure now though. So you can think like, okay, well I know amoxicillin, that's a good PO antibiotic. I'm going to see that all the time, right? Ampicillin's a good IV version of that basically, right? Another thing to think about as well is when you get cultures and sensitivities back is the cross resistance that happens there. So for instance, if I have a patient who cultures out a bug that is resistant to ampicillin, I automatically know it's going to be resistant to all the aminopenicillins. So I know that means amoxicillin is not going to work either, right? And so it's an important thing to consider is like whether, you know, when you see something that is resistant or susceptible, that usually applies to the whole class of the drugs in that case, right? So if I see that it's susceptible to, you know, we'll talk about cephalosporins in a second, our first generation cephalosporin, then I know any first generation was going to work for that bacteria. I don't know, you know, different drug companies, you know, come up with their own varieties of things. It's like, you know, why don't we have just one ACE inhibitor that we use for everybody for their blood pressure? Well, you know, because there's money to be made, right? So if you come up with different versions of it, you know, then you can get your own patent and go with that, right?
That's just highlighting that those three medications are good against MSSA.
MSSA, right? Good. So if I had a question on a test that says, hey, you have a patient, no known drug allergies, they cultured out, you know, MSSA that was susceptible to methicillin, which of the following drugs would be the best narrow spectrum drug to use for that? And you'd pick out like dicloxacillin or something, right? Okay. Up next, we have the Antipseudomonal Penicillins. What does that tell you about that drug? It'll kill Pseudomonas. This is a good first one to think about as far as Pseudomonal coverage goes, right? So again, it's one of those key bugs that I'm going to mention here that you want to, you know, kind of prick your ears up for. This only comes in combination with tazobactam, at least that I've seen in the past, you know, decade or so that I've been working. Zosyn. So if you're here, Zosyn, that's a common name. So actually, just as a side point, I recently went to a conference. Actually, earlier this week, it was the NCCPA. Anyone know what they do for you? What do? They make the pants, right? So it was an exam writing conference, which, you know, super exciting stuff. It was awesome though. It was great. I learned all about exam writing. I learned how to make better exam questions. I learned about the stats that go into it. So now when I'm reviewing the test, I can look at it and be like, okay, well, you know, this one looks like, you know, people are just randomly guessing on everyone. So I know that maybe that's a bad question, or I can see that, oh, the really high performers are always choosing the right answer versus, you know, I can look at all kinds of stuff now. But other things, some tips that we got. I don't know if it's gonna be good for your grades or bad for your grades. We'll figure it out. We'll see how it goes. It'll depend. However, some of the things that we did glean from that from the actual pants, because again, you're talking to the people that are writing it, that are designing it, and things like that. So the question is, you know, 4 or 5 answer choices. You guys do your standard of 5, right? Pants is going to go either 4 or 5. So you're going to find a mixture of the two there. Now, again, what's the benefit of having 5 versus 4? Yeah, 4 options to rule out. That sounds harder, right? So really, there's no benefit to doing it, right? So again, if you have 4 good distractors, right? So distractors being the wrong answers versus the key being the right one, there's no actual benefit, right? Of 4 versus 5. They don't really find that. As long as you know the information, you can find the right answer, right? The thing that it does cut out on are people who are just guessing, right? So if you have no clue, you're just guessing which one's the right answer, having a 20% chance is obviously worse than having a 25% chance if you have 4 choices there. So again, maybe you guys are, you know, kind of training in high gravity, so to speak, to where you have 5 choices all the time. So maybe you get a little bit better, get better at trying to pick out that actual right answer and not guessing quite so much, maybe. Who could say, right? But again, it doesn't really matter is what they were kind of telling us, which is interesting. The other thing is because anytime they change a question, they have statisticians that do all this work with these exam questions. Anytime you change any bit of that question, they can't use any of those stats from before, right? Because again, it's going to be apples to oranges at that point. So one thing they know with the drugs, they will only put the generic names. Okay, because things like, you know, brand names may go out of maybe discontinued, and then you have to change that question. All the stats are gone, right? If they don't want to show any kind of undue, you know, financial bias towards one company versus another, so they just don't put brand names. For my purposes, I will still always put generic followed by the brand in parentheses. However, don't get used to that, right? Because again, when you take the pants, you're only going to have the generic available to you, right? So for instance, no one in the hospital says, oh, let's give the patient piperacillin tazobactam. They just all say Zosyn. But when you see piperacillin tazobactam, you need to recognize, yes, that is Zosyn. I know what that is, but be able to recognize that, you know, pip-tazo, that's the generic there. Okay, so just a little bit of info.
Do they not put the brands on this like most recent pants, or?
They should not. Based on what they were telling us, and again, I've never taken the pants myself. Obviously, I have several pants, but I do not take the pants. But you know, they should not have, right? Because again, that would have to, if they took that out, they'd have to change all the stats on all their questions, right? And so those stats are very valuable because again, when they're testing all ththese thousands of PAs, like they need to, you know, actually make sure they have good questions there. Okay. So anyway, it's a little aside. But getting back to the topic at hand, the pip-tazo, very good broad spectrum antibiotic, right? This has really good coverage against anaerobes, which is one of its hallmarks, that it covers anaerobes like stuff in the gut. This is going to be really good broad coverage against gram-negatives. This means Pseudomonas is included with this, which is good. It's also kind of pretty good gram-positive coverage, up to and including MSSA. Now, if you had an MRSA infection, this would not cover that. But up to MSSA, you'd be totally fine. This means that if you had a patient come in, say from the nursing home, and you weren't sure what they had, this is a good drug to start out with from a broad spectrum sort of standpoint because this is going to cover a lot, okay? Doesn't cover MRSA, so if you're worried about that, we'll have to include other drugs, which we'll look at in a moment, but this is good for covering that. So again, also good for polymicrobial infections, meaning you have more than one bug that's causing the infection here. This is good for nosocomial infections. We said nosocomial means what? They acquired it from the healthcare field, basically, right? We gave it to them. So you'll see this used a lot for pneumonias, intra-abdominal infections. If we have a patient who comes in for appendicitis and we believe that it's ruptured, we will use Zosyn for that patient because we know that's going to cover basically all the stuff in the gut that could be leaking out into the abdominal cavity, right? And then Pseudomonas is the other big point here, okay? Now, again, this is good because broad spectrum sort of drugs, right? This is kind of like the bazooka of things we've been talking about so far. Good that it covers everything, and it's really, you can make that knee-jerk reaction and say, well, I'm just going to give this to everyone. But the problem is resistance, right? So again, you need to be very, judicious in your use of this drug. And in fact, very frequently, this is one that we will put on a restricted list to make sure that you have a good indication to use it. So for instance, at Nemours, we have a list of drugs that you cannot get access to unless you have approval from the infectious disease doctor, okay? Now again, that's not trying to supplant to say we know better than you, But as a group, we've all come together, right? There's an antimicrobial stewardship group that comes together full of doctors, pharmacists, nurses, everybody comes together and they say, well, we want to hold off on these drugs. We want to make sure you're not using these, just for every single patient who comes in the door. So that way, you as a provider, say you're working in the ER, you want to give your patient a dose of Zosyn, you got to call the ID doc up, say, hey, I got this patient, I think it's a ruptured appendicitis, blah, blah, blah. And they'll say, yeah, I give them my blessing, right? Or they'll say, no, I don't think so. Maybe you should use this instead. And then you can, based on the dialogue, maybe make a different choice there, okay? And then we as a pharmacist will double check to make sure that actually has occurred and make sure you get the antibiotic. Because once we lose Zosyn, that's bad because then you don't have a really good drug to cover a lot of those bacteria. Yes, ma'am.
Sorry, did you mention why crossed out?
Yeah, because you don't really find piperacillin by itself anymore. You only find it really in combination with tazobactam. Yep. Anyway. So again, still time-dependent killer, still bactericidal, so nothing really changing with that one. Which actually is kind of cool. Nowadays, we're actually doing more extended infusions where instead of giving the drug, say, every 6 hours is maybe like a half-hour infusion where you get a high peak, but then it drops down pretty quickly there. We'll give it over a 4-hour period. So again, we can kind of get a nice longer plateau sort of thing above the MIC and then drop it down, right? So again, more time above the MIC, the better kill you're going to get with these time-dependent killers, right? Again, watch renal function. Again, side effects, monitoring is all going to be pretty much the same here, okay? All right, so those are the penicillins. Moving on, next we have the cephalosporins. Now notice the structure is a little bit different, but they all have that beta-lactam ring. So again, the mechanism is still the same here, okay? However, the coverage is going to be much different based on which cephalosporin we're talking about. So, nice things about the cephalosporins, they have good CSF penetration. So why would that be useful? Meningitis, right? So that's why when you look at first-line treatment for meningitis, you'll frequently find a cephalosporin on there because, again, things normally don't cross the blood-brain barrier very easily. We like to keep things out. But if we have good drugs that can get across, that's fine. Now, if you talk about meningitis, you'll find some drugs can get across no problem no matter what. Some drugs only get across when you have that inflammation. You actually open up those kind of gaps in the blood-brain barrier. We'll talk about some examples later on. But cephalosporins are great for crossing, okay? Now, if a patient comes in and they say, I'm allergic to penicillin, the next question you always want to ask is what? What type of reaction you had? They say I had diarrhea. Is that legitimate? No. They say my throat closed up and I had to be intubated. That's legitimate, right? That's a true anaphylactic reaction. So you need to take this all into account. Now, and again, you may hear differing opinions based on how new or old the evidence the practitioners are working off of. I will tell you, at least from the review articles that I have read, things that I will give you my personal stance on things. That was another thing I meant to mention last week, is that, students like to have one right, one wrong answer, right? They like to know things are black and white. Medicine's not like that, right? So again, if you go into a different class and they say something that is maybe different than what I say, that's okay. Does not mean that I'm right and they're wrong. Does not mean they're wrong and I'm right. Doesn't mean anything. It could just be we have different perspectives on things, right? So again, oftentimes the better way to pose that is not to go, well, Dr. Wood said this. Not a good tact, right? You want to be a little bit more respectful. Like, oh, interesting. I heard Dr. Wood say this. Like, how come you do that? Like, what evidence are you pulling from, or what's your clinical practice been, your relevant experience, etc. You'll find you get a lot more, flies with honey than vinegar, as the saying goes. And so again, be curious, right? Don't be judgmental when you come into this thing. Or come back and ask me, like, hey, they said this in this class. Well, why is that different? We can try to come up with an answer, right? I'm coming from a pharmacist background, peds, toxicology, emergency medicine, someone who's coming from, a PA working only with adults and geriatrics. Like, they have a very different perspective than me, and that's okay, right? Again, because there's multiple ways to skin a cat. We can all come together and try to find a good happy medium. So that way you're starting to form, again, looking all at the same picture of medicine with different angles, you get a better full picture. That make sense? So again, don't use that thing of like, Dr. Wood said this. Not going to fly for a lot of people, okay? Anyway, my name is pretty much mud anywhere I go anyway, so again, that's not going to save you. So anyway, so the thing that goes into penicillin allergy, so for the longest time, the prevailing logic was if you were allergic to penicillin, that meant that you were allergic to cephalosporins, okay? That's bad because if you can't get a penicillin and then you can't give any of the cephalosporins because it's allergy, that's a lot of drugs you can't give to that patient, right? It's a lot of your antibiotic armamentarium that is now gone. You don't want that, right? So what the actual thing that was happening was for a long time, where do we get our penicillin from? From molds, right? So again, we didn't have the nice synthetic ways of making a lot of these drugs very early on. We had to use bacteria or molds and things like that to actually produce it for us. What they found was a lot of penicillins were cross-contaminated with some of the cephalosporins, and cephalosporins were cross-contaminated with the penicillins. So when you gave a patient who was allergic to penicillin, yeah, they had a reaction, but if you gave them a cephalosporin that was cross-contaminated, they also had a reaction. So that's where that prevailing logic came from, like, okay, well, obviously they have a cross-reactivity. Nowadays, we have very pure drug. Okay, so there's no penicillin in your cephalosporins, there's no cephalosporins in your penicillins. Okay, that means that once we have that new evidence, now we're looking at the actual cross-reactivity. If you have a true blue anaphylactic reaction to penicillins, the chances of having a reaction with the cephalosporin less than 1%. It's pretty good odds, right? You're not going to have a reaction. I will still have plenty of docs, PAs, nurse practitioners that say, I don't want to try it. I don't want to push it, right? That's fine. What can you do in the meantime, though, right? So if I have them in the ER, guess what I can do? Give them a test dose, right? And then we don't usually do like skin testing like that. It's more like in the allergy clinic you'd see that, or immunology clinic. But I can give just an oral dose of cephalosporin, right? So they say they have a true penicillin allergy. The other thing you run into is a lot of people say, well, you know, I don't know, my mom told me I was allergic to penicillins. They had no idea what reaction they even had in the first place. Like that, I'm just like, man, whatever, let's try it. Because if you're going to have an anaphylactic reaction, where would you rather be? Right? Yeah, you'd rather be in the hospital anyway, especially the ER where they can actually take care of that. Not that I'm advocating you give your patients anaphylactic reactions, but if you believe the chances are very low of that actually occurring, that's good because then you can give them a cephalosporin. You find they have no reaction, now you're good to go. You can give them any cephalosporin you want. Now you have documentation saying that yes, they were tolerating this just fine. You know, give them a dose, you know, see how they do for an hour or two, and then send them on home, right? So this is a good thing, a good point. And you may find a lot of old school practitioners who I've tried to argue with tooth and nail for a better part of an hour, and they still will not budge on it, right? And again, you guys are practitioners, so you guys make the ultimate say. However, you know, it's always good to be able to collaborate and try to listen to reason. And again, if I can provide those articles and things like that that showed them that, sometimes that can sway them in the right direction.
Do side effects typically happen pretty immediately, or is there any delays?
It depends, right? So if someone has a true penicillin allergy, right, they've already been sensitized to it. They already know they're going to have anaphylaxis. If I were to give them something that would also trigger that as well, then it should happen pretty immediately, right? Within, you know, 20 minutes, within an hour, I would expect to see something, right? Now, again, with penicillins, if they say they're allergic to penicillin, that's true. I would not give them Zosyn, right? I would not give them piperacillin because there's enough structural similarities there. The thing is that a lot of people thought the beta-lactam ring is what they were having a reaction to. That's not true. It's the side chains they're having reactions to. And the side chains for penicillins are way different than cephalosporins. So really, there should be no cross-reactivity there. But, you know, if I give them, you know, say Rocephin or something like that, you don't have a problem, then they're good to go. I can give them any cephalosporin at that point, okay? Now, there's going to be those unique individuals out there who are going to be reactive to everything. And in fact, I always love those patients who you can tell they've been to the allergy clinic because their allergy list is going to say like wheat and dog dander and trees and pine nuts and there's like 40 different things they're allergic to. I'm like, how do they even live? Like, my gosh. But you may find those people that are like really allergic to, you know, penicillins and cephalosporins, and it's legitimate, you know. So people who tend to be allergic to some stuff tend to be allergic to other stuff as well, right? They just have to have this ramped up immune system. But anyway, so enough of that. Side effects are very similar to the penicillins here. Not a whole lot of differences. Again, look for allergic reactions, nausea, vomiting, diarrhea, nothing really special here. One thing to note as far as coverage goes, the spectrum of activity or the coverage of these antibiotics is going to change based on the generation that you're looking at. Okay, we're going to talk about 5 generations. I think I included the 5th, but if not, we're going to talk about at least the 4. The 4 workhorse ones that you're going to see most frequently, though, at least are going to see that the spectrum changes as you go up in generation. Okay. Now, as far as antipseudomonal activity, there's only 2 of these that are going to cover Pseudomonas: ceftazidime and cefepime. Okay, so keep those in the back of your mind. We're going to talk about those later. And then again, mostly renally eliminated. There's one notable example of a cephalosporin that is not renally eliminated. We'll talk about that in a moment, but keep in mind the other ones need to be renally dose adjusted. Okay. So getting into it, as far as the generation goes, what you're going to find that as you move up in generations from 1, 2, 3, and 4, you're going to find that gram-negative coverage typically increases. Okay, so as you go along, you're going to find that, say, a 4th generation has a lot better gram-negative coverage than a 1st generation agent does. Okay. On the other hand, you're going to find that typically gram-positive coverage will go down as you go up in generation until you get back to the 4th generation, right? So of course we like to screw up and always change rules at the very end there, right? But you're going to find with the 4th generation, they actually don't really sacrifice a whole lot of gram-positive coverage. That'll be increased. Okay. None of these are going to cover MRSA though. Okay. So another note there that we have not still uncovered any drug that works on MRSA yet. We'll get there, but we have not reached any yet. So 1st generation cephalosporins, these are used quite frequently. You're going to find that Ancef or cefazolin, some people say cefazolin, doesn't really matter, is going to be used very frequently as an IV antibiotic in the hospital. Okay, Keflex or cephalaxin is the kind of go-to sort of PO antibiotic you're run into very frequently, right? And again, these, even though they're 1st generations, they still have a lot broader coverage than you would see with, like, you know, kind of the OG penicillin, right? So for instance, with the 1st generations, you already cover MSSA, right? You already start off with staph coverage, not the same way. No MRSA yet, but MSSA. But these are good for, especially ANSEF, you're going to find used quite frequently for surgical prophylaxis, right? This means that before anyone undergoes surgery, they're probably going to get a dose of ANSEF, right? Because anytime, obviously you're cleaning off the patient, right, trying to disinfect them, but you still want to worry about any kind of skin stuff that can get in there. And again, when you think about skin stuff, what are you thinking of? Yeah, gram-positive, staph, strep, things like that. So by kind of giving them a dose of ANSEF systemically, you kind of cover them and try to prevent any infection from taking place. Typically, you'll give them 24 hours of coverage. So for instance, this is given every 8 hours. So they'll get, say, a dose right before surgery, usually within an hour of the incision time, and then they'll get, say, 2 doses afterwards to cover them for 24 hours, and that generally prevents most infections from occurring. Is that a guarantee you're not going to get infected? No, but you generally will keep most patients from being infected there, right? Some UTIs can be treated by this, some of the more minor ones, but for the most part, you're going to see this used for a lot of surgical prophylaxis, MSSA, things like that. Keflex, very good for more run-of-the-mill sort of skin and soft tissue infections. You're going to see this used quite frequently for UTIs. However, though, they run into resistance quite frequently. So, for instance, if I had a patient who came in for UTI, we'll talk more about this like in the GU section later. But, if this is their first time having a UTI, I can probably get away with giving them Keflex because they're very unlikely to have resistance to that drug. If it's someone who's coming in for their 4th UTI that year, they've been on multiple courses of antibiotics, guess what? They're probably going to have more resistant bugs here, and something like Keflex just isn't going to cover it, right? So good for run-of-the-mill stuff, uncomplicated things. This can be used pretty widely there. Again, no anaerobic coverage, so would not use it for any kind of gut stuff. Or you could use it in combination with other drugs that cover anaerobes, but again, will not cover anaerobes by themselves, okay? Oh, as a class, just so you know, as a class for the cephalosporins, they do not cover Enterococcus, right? It's a gram-positive bug in the gut, but does not cover any cephalosporin, cover Enterococcus. So just one note there. It's a notable hole that's covered.
So no cephalosporins?
No cephalosporin is going to cover Enterococcus. So I don't know why that is. It's just an interesting hole in this coverage that just does not cover it, right? Up next, we have the 2nd generation cephalosporins. So again, now we're moving up. We're getting a little bit better gram-negative coverage, losing some of that gram-positive coverage. But here we have a couple agents. This is probably the least used group of cephalosporins you run into. So I'm not going to list every single cephalosporin out there, but at least going to list kind of the more common ones you run into. So things like cefotetan, we have cefoxitin, cefuroxime, and cefprozil. Again, they get a little bit better gram-negative coverage than the 1st generation, so they'll cover more things like your H-flu, some Enterobacter, things like that. And it sometimes can be used for surgical prophylaxis, UTIs, upper respiratory tract infections. And again, just based off of this, I'm not going to ask you specifically which one of these can you use for an upper respiratory tract infection. When we get to ENT, that question is then going to come up, right? I'm going to ask you 1st line, 2nd line agents for that sort of thing. But here, we're just kind of getting you some exposure to where you might see these drugs being used most frequently. That kind of makes some sense. Now, on the other hand, you're going to see a lot of 3rd generation use, okay? Anyone ever heard of Rocephin before? Ceftriaxone, that is a workhorse antibiotic. It's probably one of the most frequently used parenteral antibiotics you're going into, especially from like an urgent care or ER sort of setting, right? So ceftriaxone, this one is notable because it is not renally eliminated. Only gets metabolized to the liver. So if I have someone with really poor renal function, I do not need to dose adjust for my Rocephin. Most everything else we talked about, at least so far, has been renally eliminated. So this is one kind of nice thing about that. If a patient is on dialysis, guess what? Still give them the normal dose of Rocephin. They have no problem with it whatsoever. The other thing, right, we talked about all these, beta-lactams so far. They've all been time-dependent killers, which means how often do I have to give them usually? Pretty frequently. Q12 at a minimum, but usually Q8, Q6. Ceftriaxone, ceftriax 1 at the end there, only has to be given 1 time a day most of the time, which is nice. Long half-life, so it's going to stick around for a long time. So I can just give a single dose, and I'm good for that whole day, which is very beneficial from a compliance standpoint.
So, would you want to avoid this if someone has cirrhosis with a problem?
Potentially, right? So it all depends on how significant their hepatic dysfunction is, but it's something you want to monitor for, right? So you may need to adjust some dose, but as you'll find, you're more frequently going to run into patients with significant enough renal dysfunction to cause you to change your dose, and you are to find patients with significant hepatic dysfunction to cause you to change your dose. If that makes sense, right? Lots of patients with hepatic dysfunction, but it may not be so severe that you actually have to change the dose of your drugs all that significantly, right? But anyway, another good thing to note here, this is very good strep coverage. And so one of the things you find when you're treating a lot of upper respiratory tract infections, so say like you give a patient amoxicillin for an ear infection, it just does not go away. It's just super resistant. This is a good fallback, right? If you have to switch over. If they look really sick as snot when they're coming in, you know, no pun intended because they have a respiratory tract infection, but they come in, usually Rocephin's a go-to like IV sort of antibiotic because of the fact that it has really good strep coverage. And because we overtreat things, strep has become pretty resistant in some places. One thing to note, though, you cannot give this drug in the first 30 days of life. The reason for that is, remember we were talking about neonates, we talked about some of the differences there. We talked about things like serum proteins, right? We talked about how the serum proteins will change based on that first month of life all the way up through, young childhood and adolescence. There's an interaction here where bilirubin normally likes to bind to albumin in neonates. Ceftriaxone also likes to bind to albumin. So if ceftriaxone comes along, it will kick off that bilirubin, off the albumin, bind to it instead, and now you have all this free bilirubin floating around. That can cause jaundice in the neonates. We do not use this in the first 30 days of life. As an alternative, we'll use cefotaxime. So cefotaxime you can use, this is almost predominantly used in the neonatal period. I've not seen it ever used in an adult patient, but ceftriaxone can be used quite easily for those anyone greater than 30 days of life. Okay, makes sense? Anywho, actually, in ceftriaxone is kind of interesting. You can't mix it with calcium. So this is where things like IV compatibility, if you're not sure, always ask the question, especially call up your pharmacist and they can tell you. Because actually, if you mix this with any kind of calcium-containing products, it will precipitate out, will crystallize out, either ruin your line or potentially get into the patient, and then they can have an embolus form in the lungs or something like that. So you have to be really careful with some of these incompatibilities. It's kind of interesting if you see that. Ceftazidime does have antipseudomonal coverage. Notice ceftriaxone does not, but ceftazidime does. The problem with ceftazidime is that it develops resistance very quickly to Pseudomonas. We don't use it routinely if we were worried about a Pseudomonal infection in a patient. What we'll actually do is save this in case there's a particular strain of it that is only sensitive to ceftazidime. I only frequently use this in special cases like cystic fibrosis patients, but just know it does not retain that susceptibility for very long. It will become resistant over time. Okay. A good oral third-generation antibiotic, which would be kind of a good sort of alternative to, say, using IV or Rocephin, is going to be Ceftonir. This is probably the most common one you're going to run into from a PO route, and Cefixime is another good one as well. Okay, but Ceftonir, Omnicef is nice because it also has a pretty long half-life. You can actually give this either once, twice a day, which is good from a compliance standpoint as well.
So it's not a time-dependent killer?
They're still time-dependent killers, but the half-lives are long enough that they still stay above that MIC for a sufficient period of time. Okay. So again, they're still having that same type of killing because they still have the same mechanisms as any other cephalosporin or any other penicillin, but they stick around long enough that they still are above that MIC.
So would that be like their post effect?
It's not really post-antibiotic effect because they're above the MIC, so they're still having that that killing there. But the post-antibiotic effect, the levels have dropped below the MIC. You're still preventing those bacteria from growing, right? It's kind of the difference there.
And they're also still bactericidal.
Still bactericidal, right? So again, this has not changed because the mechanism is still identical, right? Okay. Again, ceftriaxone, again, just one time a day, which is, again, very nice, very frequently used in the hospital. You're going to do this all the time. You can always correct me, though. If I say something super stupid and you're just like, what the heck is he talking about? Didn't you mean this? And I'll be like, oh, yeah, I probably did, right? So, again, anyway, so any questions from the first half we had there? Yes?
So you said meningitis, cephalosporins can cover that, but is that for third generation disease best for meningitis or any?
That's used most frequently. So the thing with meningitis is you may not always have a definitive on, and again, this won't be on the test specifically, but you may not always know what bug it is specifically you're trying to treat there. So you go with something a little bit more broad spectrum. So Rocephin gets used very frequently in that case. If you're not sure, you just go ahead and use as broad of a gun as you can to try to cover most everything, right? And then as cultures come back, then you narrow it down based off of what the cultures show, right? But anyway, so moving on, next we have the 4th generation cephalosporin. Now, note there is a 5th generation. I did not include it in here because it's still very relatively new. It's still very expensive, and you're not going to find it in really heavy rotation yet, right? I'm trying to show you stuff you're going to find most frequently out there in the hospital or in the outpatient setting, things like that, right? So again, these are things you're going to find all the time when you're working either in the ICUs, working in the ERs, working urgent cares, wherever you happen to be. Okay, so the 4th generation cephalosporin here is called Cefepime, or Maxipime is the brand name. It's a very broad spectrum. Think of this like Zosyn, right? It has a very good broad spectrum coverage. The one difference that this has is that it does not cover anaerobes, okay, but it does cover Pseudomonas, which is good, right? So good broad spectrum coverage, covers gram positives, No MRSA though, right? Still no MRSA. We've not covered anything that does that yet. Or Enterococcus, because again, it's a cephalosporin. It still does not cover Enterococcus, okay? This is really good for patients who have things like neutropenic fevers. When I say neutropenic fever, what does that mean? Yeah, neutropenia. And they have, yeah, so they come with the fever. You don't know where the infection is really coming from because again, they don't have a good immune system to ram. And again, sometimes that's the only sign that you can see. The only symptom they're developing is this fever here. And so you're trying to cover them for kind of anything. It could be UTI, it could be pneumonia, it could be all sorts of things. You cover them with something broad spectrum. So cefepime is used very frequently, especially a lot of our hem-onc patients who are coming in who are neutropenic. Like they get hammered with this very early on, right? Nosocomial infections, you're going to use this frequently, and obviously Pseudomonas is the other big thing we're going to use this for quite often. Okay. In fact, what I tell people is, I say try to rely more on cefepime than Zosyn if possible, because again, Zosyn is one of those ones where if you don't need that anaerobic coverage, then you don't need to use it necessarily. Cefepime is going to do just as good of a job 99% of the time. But if I have like a complicated gut infection where I'm worried about anaerobes, that's where Zosyn is really going to be able to give me some good utilization there, some good use, right? Up next, we have a brief one here called the astrienam, which is a monobactam. Notice it's still a beta-lactam though, right? Still have that same square ring structure there. Only thing to note with this one, it does cover Pseudomonas, but it only covers gram-negatives. There's actually no gram-positive activity whatsoever with this drug. Its claim to fame for a good long time was they were saying, well, there's no cross-reactivity with patients with penicillin allergies. You can use this no problem. Nowadays, that's less clinically important because we understand that we can give other drugs. If you say you have a penicillin allergy, you're probably okay to give cephalosporin 8 times out of 10, right? You're probably okay to give a Carbapenem, which we're going to talk about in a moment here. So just know, very narrow coverage. It does cover Pseudomonas, but only going to hit gram-negatives. And again, when we get to the aminoglycosides in a few minutes here, this is going to have very similar coverage to aminoglycosides. You're going to be able to lump those together in your mind as far as coverage goes. Okay. Again, renal dosing considerations need to be considered there. Again, no specific things to note as far as like allergies or adverse reactions, anything like that. Again, very similar to all the other penicillins and other beta-lactams we've already talked about so far. Okay. Okay, up next we have the Carbapenems. These are like the nuclear bombs of the group here, right? So we have a couple of them. We have Imipenem, we have Meropenem, we have Ertapenem, and then Doripenem. Again, when you can, try to latch on to these naming conventions to try to help you with the categorizations, right? So again, if I see Cillin, you probably know you're talking about a penicillin, right? If I see Ceph at the beginning of a name, CEF, you probably know it's a cephalosporin. I wish there was a better way to delineate the different generations. There just isn't one, unfortunately, so you're going to have to spend some time memorizing that. But if you see Penem, chances are probably going to be a Carbapenem, right? These are super broad coverage. They will cover anaerobes, they will cover gram-positives, not MRSA, but they will cover MSSA, they will cover gram-negatives, including Pseudomonas. These are really good broad-spectrum drugs. If you've got a really sick patient coming in from the nursing home and you're considering they have a healthcare-associated infection, a nosocomial infection, and you don't know what the heck it is, give them some meropenem, they're going to be good to go for the most part, right? So you're going to find that when you need broad coverage, this is a very good agent to use, okay? The only exception here with Pseudomonas is ertapenem doesn't cover it. I don't really see a lot of ertapenem being used here. And in fact, for most hospital formularies, because again, does every hospital have every drug available to them? No, you have to be conscientious about what drugs you're going to have on formulary based on cost and based on other things like you see, what patients you see often. Like meropenem is the most frequent one I ever see, right? But again, I've only mainly been practicing in Florida. If you go somewhere else, you might find something different. But this is really good for multi-drug resistant gram-negative infections. Okay, even some bacteria will produce what we call ESBLs. It's called extended spectrum beta-lactamases, where even if I gave you Zosyn, as tazobactam in it, that beta-lactamase can still chew right through it, right? This is even more resistant to that, right? So again, if something like Zosyn didn't work or something like Unison didn't work, this could potentially still have some activity, right? And that's what the cultures are going to tell you when it comes back. So if you had a culture come back and it said, hey, we got Pseudomonas growing here, it's resistant to piperacillin tazobactam, but susceptible to meropenem, that's due to that fact that it may be producing an ESBL, but this can still retain some activity. Okay, so that's kind of the nice thing here, is an even bigger gun than cefepime or than Zosyn would be. Okay, so this is kind of like the biggest broad spectrum drugs we've talked about thus far. Okay. Anyway, so good for those ESBLs, good for nosocomial infections, good for things like meningitis. It's very good penetration. If you didn't want to use Rocephin, you could use this as an alternative potentially, right? Again, very low cross-reactivity. So if you had someone who's really allergic to penicillin or cephalosporin, this is not going to cross-react with that, right? So that's kind of the other nice thing about it. So is this something you would probably start out with most of the time? Generally, no. This is again too broad a spectrum even for that, right? For for most patients, if I need something broad spectrum, like a third generation cephalosporin, Rocephin, great drug for covering a lot of stuff. If I have someone who's like in a special use case, like they're immunocompromised, that's where I can bump it up to like cefepime, ricazocin, or something like that. This is for like the sickest of the sick for the most part, right? Really relegate to a lot of your ICU sort of patients who are very, very ill, right? Yes, ma'am.
Could we go back to the first?
I can't go back with the recording, but just tell me what you're asking, and I can try to.
Okay. So you know how you have penicillin?
Mm-hmm.
Okay, in that order.
Yep.
Is that like an order that we should know? Like.
No, there's all carbapenems. Just know they're all fit in that same.
They're all equally effective.
For the most part, yeah. We'll talk about some notable exceptions here. So one of the things to know, at least with imipenem, is imipenem is generally not used for the most part, and that's actually due to the fact that with patients with renal dysfunction, and again, these are renally eliminated, if you have renal dysfunction, you do not dose adjust for that. Levels can build up, and this can actually cause seizures. That's a unique side effect. Again, when you're going through these categories of drugs, it's important to know things like general side effects of, say, penicillins, general side effects of carbapenems. If you have the time, right, because again, school's all about triage and trying to learn as most that you can, but again, some details are going to go through the cracks. I understand that. I get it. I've been a student before. These are the little details you can drill down on that may be a small subset of the questions, but they're not going to be the main bulk of things, right? So again, if you can go down and remember, okay, well, imipenem I know causes seizures in renal dysfunction. That's a good thing to know. It's not the most important thing to know. I'd rather you know things like general coverages for these antibiotics, but that's a good detail I can potentially ask a question about, okay? So again, unique little differences between the drugs. Those are probably the last thing you should focus on, but may be present there for some of those more nitpicky sort of questions, okay? Still a good clinical point, right? Still good to know if you had to select a drug for a patient, you said, well, they got renal dysfunction, they're on intermittent dialysis. Imipenem is probably not a good drug for them because of that seizure risk. Or if they have a seizure history, I probably don't want to give them something that's going to be pro-seizure inducing, right? So again, these are things to think about. There are still good clinical details, but if you only have limited time, which you do, focus on the broad stroke stuff first and then drill down to these little details later on, okay? These are really good quiz questions like asking if you're studying in a group, go back and forth like, okay, if a patient has seizure history, comes in with pneumonia, what's a drug you want to avoid? Imipenem, right? Now again, I will not ask negative questions. I will not ask which of the following accept, or which of the following is false, or which of the following can you not give the blah, blah, blah. Those are questions that will not be asked. Also, from the PANT stuff, they don't ask negative questions either. So again, just focus on what you actually know rather than being able to parse out like, okay, well, I know these things are true, but this one's false, right? They don't really ask questions like that, okay? Anywho, right, so those are the main things to note with this one. So those are all the beta-lactams, right? So we had the penicillins, cephalosporins, you had the monobactam, and then you had the carbapenems. Those are the beta-lactam drugs, okay? They all work on the cell wall, right? They all interact with that penicillin binding protein, okay? This is still a cell wall active drug, but it's working by a different mechanism. This is called vancomycin. This is another workhorse antibiotic, especially on the inpatient side. You're going to see this used all the time. If you want broad spectrum, gram-positive coverage, this is your drug, right? What do you notice about the size of the molecule? Huge, right? This is a drug that does not cross that blood-brain barrier very easily, right? Unless you have meningitis and you have nice inflamed meninges, you can actually cross that blood-brain barrier. But this is a very big molecule, and it actually has some important factors as far as things like, does it get absorbed across certain membranes? Does it get, how is it going to be eliminated? Things like that. So we'll talk about that point in just a minute. But just note that it's a pretty big molecule. Anyway, so this is not a beta-lactam, and actually works through a little bit different mechanism that you're going to see than the penicillins did. Because penicillins had to work on penicillin binding protein, this does the same thing basically. It interrupts those cross-links, but it doesn't require that binding to the penicillin binding protein. It kind of does it directly itself. So because of that, it's able to have wider ranges of activities, specifically against gram-positive bugs. Okay, this means that it covers MRSA. So this is the go-to. If you're worried about MRSA, this is one of your go-to drugs for that, especially if you need IV therapy, because it's such a big molecule. It actually doesn't get absorbed from the GI tract. Now, does that mean we never give it orally? We're going to find that no, that's actually not the case, which I'll talk about in just a second. And again, gram-positive coverage only. If I ask on a test question, hey, you have a patient who has a gram-negative infection, or you got a patient with E. coli, which of these drugs is going to cover it? Vancomycin is not going to be the answer, right? Only gram-positive coverage here. This is good for patients if maybe they have a penicillin allergy that was true and you cannot give them any other drug. This may be used in some cases. Good for MRSA. This is also good for C. diff. So this is actually an important point here. When we get into GI, we'll talk more about C. diff specifically. There's actually 3 drugs used for C. diff. 2 of which we'll talk about here. The other one we'll kind of save for GI just because it is kind of very specific for use there. If drugs didn't work for C. diff, anyone know any other kind of very kind of intensive sort of options you have to treat C. diff? A transplant of sorts? Yeah, you can actually do fecal transplant, which I always find just completely disgusting, right? Yeah, we'll talk about metronidazole a little bit. So what's actually interesting is the metronidazole used to be first line. It's actually starting to take a back seat due to resistance. Now vancomycin is actually one of the first line drugs they're going to recommend nowadays, at least for adult patients. But anyway, C. diff, we mentioned, is an anaerobic infection. Comes up in the gut. It's more like an opportunistic sort of infection. This is going to be a very good drug to use for that. But note, PO only. Okay, if I give someone with a C. diff infection IV vancomycin, it's not going to do me a lick of good. It cannot cross over into the GI tract to get that nice local action. However, if I give it orally, it's going to be able to go down, travel through the GI tract, get very high concentrations, and treat that C. diff. Okay.
I see on there where it says anaerobes, that niacin is really good for C. diff.
That's a notable exception.
Is that one of the exceptions?
That's an exception to it, right? So those are things where I wish the stoplight metaphor was all encompassing, but again, I'm trying to focus on the broad strokes, right? Yeah. But yeah, specifically, this is an exception to that. So one of the things you want to know, like, okay, well, I remember vancomycin. What's that one notable coverage? Oh yeah, gets C. diff, right? And again, because the guidelines has just changed within the past year, that is now going to be an important thing to remember. Because if say for instance on rotations, and the doctor you're working with, the preceptor is like, okay, this patient has C. diff, they're C. diff positive. What do you want to give them? You say flagyl, metronidazole. That's going to be the wrong answer now, because now the guidelines have shifted. They may still think it's flagyl. They may not be as up to date as you guys are, because again, you're getting all of today's stuff, right? So you may be able to come in and say, well, actually, vancomycin, I think, is going to be a better option for this patient because X, Y, and Z. Right? Anyway, but the nice thing here is that it does not get absorbed in the GI tract. We're going to find that, remember we talked about therapeutic drug monitoring? This is also one of the first drugs we're going to talk about that utilizes therapeutic drug monitoring when you're using this for systemic infections. So keep that in the back of your mind. Anyway, good for things like endocarditis, osteomyelitis, where you have a lot of nasty gram-positives are going to be causing these infections here, and then sometimes used for surgical prophylaxis, but that's usually only in the case of allergies. Pretty uncommon. So note here, I'm not going to ask you specifically the dose of these drugs here. I'm not going to ask you, or if I give you a level on a test, I will give you the reference range, right? So I'm not going to have you memorize the ranges specifically, because again, you can find that stuff. You can look that stuff up. I'm not going to have you memorize all of that. But just know that there are going to be levels that are going to be associated with this. And again, to use levels, that's called therapeutic drug monitoring, right? So this is one of the first drugs we've covered so far that's going to require that. Now, note, this is still going to be a time-dependent killer. So does that mean when I'm drawing levels, do I want to get a peak or do I want to get a trough? A trough, right? What does a trough tell me? It's still above the MIC, right? So again, if I get that trough and it's too low, that's going to tell me, hey, you're probably not above the MIC. You're probably not treating that infection. So again, peak levels we don't really care about, because again, we only care about being above the MIC for the longest period of time. Okay, so this is why we get trough levels for vancomycin here. Now again, the goal trough may depend on the kind of level or the kind of infection that you're dealing with, right? So for instance, because again, we're only using the blood level as a surrogate for the concentration in other tissues, right? And so you're going to find with such a large molecule like vancomycin, it's hard to penetrate some of those tissues. So for instance, if I have something like a pneumonia, lungs can be very difficult to penetrate. So for some infections, like say for instance I had a bacteremia, right? So if I'm injecting the drug into the bloodstream, like it's probably going to be able to treat that infection pretty easily. I can shoot for a lower trough versus the lungs are hard to penetrate, the brain's hard to penetrate. I'm going to shoot for higher levels. The bones can be difficult to penetrate. I'm going to shoot for higher levels in order to get the higher concentration at the tissues to actually treat that infection. So just know that your goal troughs can range depending on what the indication may be. Okay, so depending on the type of infection. Anyway, and remember we talked about loading doses. What do loading doses help us do? Get to steady state sooner, right? So instead of having to give a drug, say 3 or 4 times before I'm at a steady state, we get the levels up high immediately, which is good, especially if I have a critically ill patient, right? If I really want to treat that MRSA right now, I can give a loading dose, get them up to that steady state level, and then I can start to monitor things like troughs right there. Because again, if I was just say giving normal maintenance doses, normal lower doses, how long does it take to get to that steady state? 4 to 5 half-lives, right? So if I check it too early, if I check a trough too early, say after the first dose, what is that going to do for me? It's going to look falsely low, right? It's going to look falsely low because I've not built up that kind of that body burden yet, that levels of it, and thus you're going to inappropriately assume, okay, well I need to give more drug or I need to give it more frequently, and then by the time you actually do get to steady state, levels are going to be too high. and there's particular toxicities we're going to talk about with this that we want to avoid. Okay. Now again, for some strains of MRSA, they're going to be too resistant. The MIC is going to be so high that we could get the drug levels high enough to treat that, but guess what? Levels are going to be so high they're also going to be very toxic to the patient. We don't want to do that. And so in some cases, that's where you need some alternative therapies. We'll talk about those in a few minutes here. But that's when you start to get into the realm of the VRSA, which is vancomycin-resistant Staph aureus.
Like, how do you know, and this probably isn't really, I don't know if this is a dumb question, but like, how would I know what the MIC level is? Like, I don't.
Yeah, so that's what the lab's going to tell you.
Yeah, because I'm trying to find it up to date, and I'm like,
Yep.
where does one get this number?
The lab will typically report that out, right? So for instance, with MRSA, because it is a particularly, it's a special kind of bug that like you really want to make sure you're treating that effectively, and because the resistance is such an issue, they will typically report out what the MIC is for that particular bug, right? They have all that information, but a lot of times, when you get those reports back from the lab, they are censoring a lot of that information because you don't want to get bombarded with all this information and not really be able to look at what's really important. So for instance, when they are looking at antibiotic, the sensitivities for bacteria, they don't show you every single drug that they actually tested. Because if they showed you every single drug, you might be like, all right, well, Zocin's going to work for this, might as well use Zocin. It's like, well, that's inappropriate. You didn't need to use Zocin. You could have used something a little bit more narrow spectrum. So oftentimes they will censor results to make sure that they kind of guide you a little bit. It sounds kind of tricky, but it kind of makes sense from just a human nature sort of standpoint. If you only see what's there, you're probably going to pick one of those options, right, for what's susceptible or not. Oftentimes we'll call them up, be like, hey, did you actually test for this other drug? And they're like, oh yeah, we did that, and it was sensitive. And that way sometimes we can change our therapy up based on that. But they'll report something like that out. If they say, hey, the MIC is greater than 2, you say, okay, well, that's pretty high. I might want to use something as an alternative, especially if getting those levels up really high, they're prone to toxicities. It's going to be hard on the patient, right? Again, don't memorize MIC specifically. Just know that as MICs climb higher, that becomes a much more resistant bug. You might need alternative therapy, right? Talk about linazolid in just a little bit. We mentioned steady state stuff. You guys remember that pretty well already. Again, don't check it too soon because otherwise it's going to look falsely low. You're going to inappropriately increase your dose there. So just to give you an example, with a time-dependent killer like this, obviously you're going to give it pretty frequently for most patients, but this is renally eliminated, just like with the penicillins. And again, you're not going to memorize this dosing necessary, but the thing I want you to illustrate is for the frequency of how often we're actually going to give this drug. So for instance, if the creatinine clearance is over 70, we're going to give it every 8 hours. They can clear that drug very easily from the kidneys. But what do you notice about as you get worse and worse kidney function? Less frequently, right? Because again, they cannot clear it as fast. So I may only have to give the drug every 24 hours in order to make sure I get the same levels as I would for someone who has good kidneys, getting it every 8 hours, right? For kids, typically kids have pretty good kidney function. We have to give it every 6 hours, okay? But for very immature neonates, for instance, what do you know about the nephrons of young neonates, of premature neonates? Pretty immature, right? So sometimes I have to give the drug every 48 hours, okay? So it can range wildly based on the actual renal function of the patient, right? Sometimes I'll just give a one-time dose, and if they have like really very little kidney function, I might just give them one-time dose and just check it in a couple of days just to see where it's at. That one dose is going to stick around for so long, they'll probably still be therapeutic even 2 or 3 days afterwards when I check those random levels. So again, it can range pretty wildly. Again, don't memorize this, but just know that as the renal function goes down, you have to give the drug less frequently. I may still give the same dose, because again, the dose is basically what's going to be the total body is what it's exposed to, but I may just have to give it less frequently and let that trough kind of go down very slowly. And then once it gets below my goal, then I'm going to redose at that point. Okay. Anyway, the big things we worry about with vancomycin is the ototoxicity, meaning what? Hearing, right? The ears are going to be affected. The hair cells, in particular of the cochlea, can become damaged when these levels are too high. Okay. Ototoxicity is a big one. This can also cause nephrotoxicity, okay? So again, the kidneys can take a hit. Now, thinking about a patient who, say, for instance, they're coming from a nursing home, they're coming in with sepsis, right? Sepsis being that kind of like body-wide systemic infection process, right? What happens to a patient's blood pressure when they become septic? Anyone know? Become hypotensive, right? And again, when the body is trying to, prioritize organs to perfuse, which organs does it really prefer? The brain and the heart, right? The kidneys can take a back seat to that. So already you're in a state where the kidneys may be underperfused, They don't get enough oxygen. Guess what? They get damaged just like any other organ would. And so now you have kidney function dysfunction from that. On top of now you're adding on drugs that can also cause nephrotoxicity. You can see how things can add up pretty quickly, right? So the kidneys are absolutely critical when you have these really sick patients to monitor for kidney function because it's going to evolve. It's going to change over time. And if you recall, back when we talked about serum creatinine, how long does that take to get to a new steady state? It takes a couple of days, right, for those levels to start to build up because of that. So again, by the time you're seeing a patient's creatinine already increase, their kidney function has been down for a while already, right? That's why things like urine output can be really good to look at, to monitor, to see, make sure they're at least still producing urine to clear that drug. Okay, so be really careful with that. Other things to note with vancomycin, you cannot give it too quickly, right? And again, this is all going to be IV. We mentioned with oral routes, only good for C. diff because it doesn't get absorbed very well. But they had this infusion-related reaction. It's called red man syndrome. Sounds a little culturally insensitive, but that's actually what the patients look like when you infuse it too quickly, right? So for instance, if you give it over, say, 30 minutes, they develop these like fevers and chills. They get very flushed, get very red, itchy. It almost looks like they're having a true allergic reaction. This is not the case, though. If you slow down the infusion and maybe give it over 2 hours, an hour, 2 hours, you're going to find that reaction will then go away, okay? A lot of patients, in fact, like a lot of hospitals will default things like vancomycin to only run in over 2 hours, right? So that way you're less likely to accidentally give it too quickly and cause that red man reaction, right? Because again, clinically it can be difficult to distinguish between a true allergic reaction versus just this infusion reaction. But noting that, hey, it's vancomycin, I know this is a probability. Let me slow it down. If it goes away, then you have your answer, right? That's one thing to know.
The red man syndrome is just localized in the area?
No, it's body-wide. Yeah, so they're going to get that all over, which is why it looks like a systemic allergic reaction, but it's not the case. Very rarely do you find patients who are truly allergic to vancomycin, which is a good thing because we like to keep that drug around as long as we can, right? We talked about monitoring. We talked about the troughs that we're going to be looking at. Again, the levels can change based on the indication and whatnot. And again, if they have really unstable renal function, that's when we're going to do like kind of random levels. I'm going to look, maybe wait a couple of days, see where their level's at. If it's below the goal, then I'll go ahead and redose them at that point, right? Okay, some examples of red man syndrome you might see in patients. Again, it looks like an allergic reaction to me, right? If you slow it down, say instead of giving it over 30 minutes, you give it over an hour or 2 hours, that's going to help to get rid of that, right? If that's truly what it is. In fact, vancomycin used to be called Mississippi mud. If you look at old pictures of vancomycin, the stuff looked like mud, basically. Like, it looked really gross, and I would not want anyone to inject that into me. But nowadays, you have a lot purer sort of drug, and now it's clear, but you can still see that allergic or that red man syndrome that can develop from that, right? Anyway, so those are all the cell wall active drugs we're going to be talking about for our purposes today, right? Next up, we have what we call the protein synthesis inhibitors. Now again, the ways that we have selectivity between human cells and bacterial cells, the targets are a little bit different, right? So for instance, we don't have that same cross-linking cell wall that the bacteria do, which is why penicillins don't really affect our cells the same way they affect bacterial cells. Similarly, the bacterial ribosomes, which ribosomes do what? They make proteins, right? So again, the ribosomes are different enough to where these drugs should be affecting the bacterial ribosomes, don't really affect us so much, okay? Now again, when you get into talking about like cancer, we're going to find that selectivity is totally gone. You're going to find that's why cancer drugs are so harmful to human normal healthy cells, because they can't tell the difference between cancer cells and our cells, right? Healthy cells. Versus here, there's some selectivity. So these are going to be protein synthesis inhibitors. Notice there's different ribosomes that are going to be here. So when you talk about 50S, 30S, 70, don't get caught up in the different ribosomes. Just know whether or not it's a protein synthesis inhibitor, okay? That's like the extra detailed nerdy pharmacist stuff you guys don't need to know. Just know it's inhibiting protein synthesis. Now, why do I care about the different mechanisms? Why would I need to worry about whether this one's cell wall active versus this one's affecting ribosomes? What does it matter? Yeah, so whether or not it's going to be bactericidal versus bacteriostatic can be important there. What if I have to use two drugs together? You want to have complementary mechanisms, right? So I don't want to have say I don't want to put vancomycin plus, or actually that's a bad example. Let's say I don't want to put cefepime plus amoxicillin. They do the same thing. You don't get any additional coverage there. However, if I were to say do a protein synthesis inhibitor plus a cell wall active drug, guess what? Now I have synergy there. Now I have increased bacterial kill based on using complementary mechanisms. Now I said double coverage is not routinely done, but we'll talk about some notable exceptions to that rule in just a little bit. But when you do that, you want to have complementary mechanisms. Okay, so just think about that. Anyway, so again, we're going to find we have several groups of drugs that fall into this category. We're going to have things like our macrolides, very commonly used, especially for upper respiratory tract infections. Clindamycin. We're going to have, we won't talk about chloramphenicol and streptogramins so much, but we're definitely going to talk about tetracyclines and aminoglycosides. These are the big ticket ones you're going to run into quite frequently. So anyway, the macrolides. Macrolides are going to be very commonly used. We have three that fit into this category. We have erythromycin, we're going to have clarithromycin, and we have azithromycin. Probably the most frequent one we're going to use is going to be azithromycin, right? This is your Z-Pats, this is your Zithromax, you use all the time. In general, you're going to only really find these being used PO unless under very specific circumstances. There's certain antibiotics, there's an IV option, we just don't really use it that frequently, and this is one of those examples here. Now, typically when you're looking at protein synthesis inhibitors, these tend to be bacteriostatic, okay? Because that kind of makes sense, because again, if I punch a hole in the cell wall of the bacteria, it's going to lyse everything out as dead, right? If I just stop these bugs from producing new proteins, they still have proteins they can still utilize that have already been formed, right? So again, you don't necessarily kill off the bacteria, but you help to prevent them from doing things like, cell division and things like that. You give the body's immune system a chance to come in and help to get rid of the bacteria, okay? So that's one of the big differences. Well, there are some exceptions, and I'll point those out as we get to them. But just know that some of these have topical products that are available. So erythromycin you may see being used either as like an ophthalmic ointment, you may see it being used topically on the skin. Different forms that are out there, but in general, we're going to find talk about specific side effects and monitoring you need to do for these drugs as a whole. So in general, you're going to find that the macrolides are going to be good for covering some gram-positive aerobes. It'll cover MSSA, no MRSA though, right? So it does not cover MRSA. Doesn't cover enterococcus, and does have some pretty good coverage against gram-negatives as well, right? So you have H-flu, Moraxella catarrhalis. This is why we like these drugs for upper respiratory tract infections, because they cover strep pneumo, H-flu, and Moraxella catarrhalis, right? When we get to ENT, we're going to come back to those bugs quite frequently there. So that's great, but still narrow enough where it's not going to be as broad spectrum as something like, Antipseudomonal Penicillin or something like that, but it has decent gram-negative coverage. The other claim to fame it has here is going to be the atypical coverage, okay? So this is where, when you talk about like an atypical pneumonia, this is what we're talking about. Things like Mycoplasma pneumonia, chlamydia, things like, Legionella. This has good coverage against that. This is the first group of drugs we've talked about that covers atypicals. Yeah, typically, right? There could be some exceptions to that, but typically think about like a walking pneumonia. That's an atypical pneumonia you think about. Yeah, for sure. Again, not used for anaerobes. Okay, so atypicals in good gram-positive, good gram-negative coverage, right? Okay. So again, we use this for a lot of respiratory tract infections. In fact, this is one of those things where we overuse it for respiratory tract infections. Very frequently, we're treating viral infections. People just want a Z-Pack, right? They just want something easy. Just give me a Z-Pack. I'll be fine. It worked for me last time. Give me a Z-Pack, right? Not always going to be appropriate, but we use this quite frequently for that because it does cover the atypical stuff. There's also some, opportunistic infections we can cover for. So, for instance, patients with HIV/AIDS can develop what we call Mycobacterium avium complex, or MAC. Some of these macrolides are good to cover that because, again, it's an atypical bug. So it's good coverage for that, right? We also mentioned chlamydia can be covered by this. So, for instance, if you say go on spring break or someone comes back, they had too good a time, right? They come back either, and again, with chlamydia, who's chlamydia's best friend? Gonorrhea, right? They always come together, right? For the most part. So that's why typically they come in, they'll get a shot of Rocephin to cover the gonorrhea, and then you usually get a dose of the azithromycin to cover for the chlamydia there, right? So again, you treat both of those together because, again, frequently they come as a co-infection there. But use that often for that. And then H. pylori, where do you find that at? In the stomach, right? Because it causes peptic ulcers, right? So it's very frequently. You guys ever heard the story of how they discovered H. pylori infections causing peptic ulcers? It's a very cool story. A guy got a Nobel He got a Nobel Prize from it. As this Australian doctor who came up with this idea that this bacterial infection could be causing all these ulcers, and no one believed him. They all thought he was crazy. So what he did was he drank the bacteria, basically gave himself an ulcer, and then treated himself with antibiotics, got rid of it, and then basically proved his theory. Super cool. Go look at some documentaries on that. There's some YouTube stuff you can find, but very cool thing. Anyway, but yeah, so you can use things like azithromycin, clarithromycin for things like H. pylori as treatment for that. So it's a very common thing you'll see. We'll talk more about that in GI later. Anyway, so looking at the side effects. Oh yes, ma'am.
A greater than C greater than B?
So that goes back to the individual macrolide. So azithro, A, C for clarithro, and then E for erythromycin. Okay, yeah. So again, you'll find a little bit of different flavor in them, but in general, I'm not going to get so nitpicky to pick one versus the other on a test, but I'll talk about macrolides more kind of in general. Now, from a GI standpoint, this is probably going to be more likely to cause things like diarrhea, nausea, vomiting, cramping in these patients. That's because there are these motilin receptors that live within the GI tract. When you stimulate motilin receptors, you stimulate peristalsis, okay? We actually use, especially in kids at least, we use erythromycin 10 times out of 10 almost for prokinetic purposes, right? When we say prokinetic, we're stimulating the GI tract to move things along, right? So if they have any kind of issues where they're not processing and having good peristalsis, we will give them things like erythromycin to stimulate that along. Okay, we almost don't really use erythromycin that frequently, at least systemically for antibiotic purposes. But yeah, so this is one of the good things there. So it's a side effect, but can also be used as a clinical indication, right? As a clinical utility.
So for constipation, never for like actual infections.
Well, at least with the erythromycin. So again, it all depends on the situation you're working in. For pediatrics, we run across a lot of GI kids who need that prokinetic stimulation. We'll use erythromycin for that all the time. Now, if they come in, they have an atypical pneumonia, then yeah, certainly we'll use azithromycin, but the lion's share of that erythromycin gets used for that prokinetic purposes. You work in a different area, though, you may find that's not necessarily the case, right? Anyway, other things, you can find some cholestatic hepatitis associated, pretty rare, but again, could be serious when that pops up. And then we don't use this drugs IV very frequently. If you give it too quickly, you can have that transient hearing loss. Not really something you want to have for your patients. We avoid that for the most part. Now, one thing that is important here to note, QT prolongation. When I say QT prolongation, where do you find that at? On the EKG, ECG, whatever. What is a QT interval? What does that tell you?
Isn't it like with the Q wave and the T wave?
That so QT prolongation, absolutely. What's happening during that period? We're actually checking the repolarization of the ventricles. Okay, so if you were I'm going to do a very poor drawing, but let's imagine you have your EKG, right? So you start off with your P wave, right? What's that? Atrial depolarization, right? Because we're just looking at the actual electrical impulse, not the muscle, what it's doing. But you have the atrial depolarization, right? Then you're going to have your QRS wave, right? What's that? Ventricular depolarization, and then you have the T wave. So again, this is a very poor representation here, but you get the point, right? The T wave is in what? Yeah, so it's the ventricular repolarization at that point, right? So basically what you're going to find is that if you have an extension here, if you find that this gets elongated, you're going to find that you're more at risk for having arrhythmias, okay? We'll talk more about this in the cardiology section later on, but basically, the heart is set up to where it has these things called refractory periods. You guys ever heard of that? Basically, where you can't have signals come along, electrical signals come along and kind of restart those cells until a certain period of time has passed, okay? Anytime you change the refractory period, you introduce the risk of having some of these reentrant arrhythmias actually start to develop. You can develop something, in this particular case, what we call torsades, the points, right? My French accent is not so good today, but so you'll hear a lot of people just call it torsades, okay? And so what you're going to find is that typically most patients, if I give them a drug that prolongs QTC, and again we usually use the corrected QT based off of it kind of fixes it for the heart rate. But anyway, you look at the QTC that gets reported on EKG. You will see that if you just add one drug on board, probably not going to be a problem, right? Most patients are not going to go into torsades immediately because I give them a dose of azithromycin. Or there could be some exceptions though. So imagine you had a patient who has a congenital prolonged QT. That patient may be more at risk, right? The other big thing you run into is when you have multiple drugs that prolong the QT interval. Okay, those can be additive, and that's where you can run into problems. So, for instance, I had a patient who was in the pediatric ICU. She had a very bad leukemia. She ended up having to have a bone marrow transplant. Anytime you're on transplant, you have to be on immunosuppressives, right, in order to prevent the rejection. When you have immunosuppression, what do you get? Well, you get side effects. You also get infections, right? Because she didn't have a good immune system now. Because we made her have a bad immune system, right? So she was on antifungals, she was on antivirals, she was on antibiotics, all of which individually can increase the QT. When you add that all together, that's where you increase your risk for developing these arrhythmias, okay? So again, just one drug by itself, probably not a big deal. Multiple drugs is where you want to think about things like getting an EKG to look for that QT interval, okay? So just something to think about. The way this happens, though, is because, and we'll go over cardiac physiology more when we get to the cardio section later on, but just know that typically when you have cells that are repolarizing, they're having potassium leaving the cell, okay? It's called potassium efflux. If I block that, that's what we're going to see, and again, here would be an example of a normal QT interval. When this gets prolonged is when you're blocking those potassium efflux pumps. Basically, you're preventing the cell from really kind of repolarizing, so kind of resetting itself as quickly. And so when you do that, you're kind of introducing the ability for another rhythm to come along and then send you into this new arrhythmia. So again, anytime you see torsades, it's not a good thing. Anyone have the treatment of choice for torsades? Magnesium, yeah. So it's a good EMT, emergency medicine sort of thing. But if you see torsades, magnesium is a drug for that. Again, we're going to cover that in ACLS and stuff later on. Anyway, so that's the first drug we came across, the prolonged QT. We're going to run across many more because again, drugs are probably the number one thing that will prolong the QT that you'll run into in a typical patient. Okay, so again, that's just the first in a long line. We'll run into these later on, so at least you know the mechanism there. Okay, now the other big thing, CYP interactions. So remember the CYP enzymes? You guys probably tried to flush that along with all the other stuff in the intro to pharm. It's going to come rearing its ugly head back, right? So again, what is the most sort of important or clinically important CYP enzyme we talked about? 3A4, right? Metabolizes a huge number of drugs. These inhibit CYP3A4, okay? So if I inhibit CYP3A4 and I have another drug that is metabolized by CYP3A4, what happens to those levels of that drug? They're going to go up, right? Because I'm inhibiting that enzyme. They cannot metabolize as quickly. Levels are going to go up in this case, right? So for instance, say for instance I have a drug like digoxin, right? Digoxin is an antiarrhythmic. One of the things we'll learn, just like with cancer drugs, any cancer drug can actually give you cancer. Any or antiarrhythmic drug can actually give you arrhythmias. So imagine you have someone who's on digoxin, antiarrhythmic, and then I put on board something like azithromycin is going to inhibit CYP3A4. Those levels go up. You increase your chance for arrhythmias, right? This can happen for any of these drugs that are metabolized by that. Now, to list every 3A4 metabolized drug would be a huge list. And just look it up, right? Anytime you're adding on a new drug, just be aware those interactions can exist. Look that stuff up beforehand, right?
Is it a cytochrome P450 inhibitor or inducer?
These are inhibitors, right? So you're going to find this is going to be inhibiting CYP3A4, and again, will cause levels to go up in those cases there. Erythromycin is probably the worst one for doing this. Azithro is probably the safest. However, some patients are more sensitive than others. You can find those small changes in levels can actually be a big difference there, okay? So erythromycin, notorious for doing that. Azithro can still do it as well. Clarithromycin is kind of in between there. Okay, moving on. Next, we have our tetracyclines. Anyone know where they get the name from? 4 rings right there, yeah. Yeah, 4 rings right there. So we're going to have tetracycline, which is a tetracycline. We're going to have doxycycline and then minocycline. Does anyone know what you call it when a wiener dog is riding a bicycle? Doxycycline, yeah. Thank you. So tetracyclines are another good broad spectrum class of antibiotics. These treat a lot of different things. Very broad spectrum, still bacteriostatic, just like our other protein synthesis inhibitors that we've seen so far, right? These will cover a good number of anaerobes. These will cover gram negatives, gram positives. This will cover things like Yersinia pestis. Anyone know what that causes? The plague, the bubonic plague, right? This will cover a lot of animal-borne diseases, things like zoonotic diseases like Rocky Mountain spotted fever, Lyme disease. Tetracyclines are a good broad spectrum for a lot of that stuff. From my realm, thinking about toxicology, thinking about things like biochemical attacks, biological attack with certain types of bacteria. Actually, if you were to have because the government keeps stockpiles of a lot of drugs that can be used for things like chemical attacks and terrorist attacks, doxycycline is probably going to be one of the big ones they're going to be handing out because it will treat a lot of these bacteria that you normally could be used for those sorts of purposes, right? But we'll cover atypicals, animal-borne organisms, good gram-positive coverage. This does cover MRSA, which is another notable thing with that. Treponema pallidum. You know what that causes? Treponema pallidum. Over syphilis, so it covers syphilis too, right? H. pylori. So again, it has a lot of different coverage here. Does not cover Pseudomonas, does not cover C. diff, but it does treat a lot of things here, right? Now, you're going to find tetracyclines have, even though it sounds like it's great, it's going to be able to treat everything, we don't use it for everything, right? We will use it for very specific use cases for the most part. One of the big ones, acne, okay? So you see this used quite frequently for acne. Some topical products, but like minocycline gets used very frequently for treatment of acne. We'll talk more about that in derm later on. These are good for atypical pneumonias. So if you have like a, mycoplasma, pneumonia, things like that, that'll treat that. And I mentioned those animal-borne diseases as well. Now, for STDs, it can be used for chlamydia as well. Again, we will talk about chlamydia a little bit later on with other STDs later on. But just trying to get you some exposure, like things you might commonly see these drugs used for. Now, problems with this. Here's a big drug interaction. First one we kind of hit today are drug-food interaction, drug-drug interaction. These will chelate with other cations. When I say chelate, what does that mean? It'll bind them up, and it will prevent them from being absorbed. So, for instance, if you were to take this with a big glass of milk, it will bind up with that glass of milk, or the calcium in that milk, and then it will not be absorbed. It will go right out through the feces, right? I take this with your iron, right, and your multivitamin or something like that, your prenatal vitamin. That's going to bind up as well, right? So it's important to separate those things out so that way you can allow the drug to be absorbed and not cause an interaction with those ions there. Because again, you can have a patient comes in, you give them a prescription, say for doxycycline, they come back in, and they still got the same infection they had before, and you're like, well, okay, well, are you actually taking it? They're like, I'm taking it just like you told me. you find out that actually they were taking it along with something like, a big glass of milk, right? Older people, you tell them to drink lots of milk for their bones. That can be the problem there, right? They're actually not absorbing it in the first place. So be cognizant of that. Other things to note. Discoloration of teeth, right? This can, because it binds to cations like calcium. Where's the biggest store of calcium in your body? In the bones, right? And again, teeth are basically just big deposits of calcium as well. And so what you're going to find is that doxycycline is probably the worst for this one. And so for adults who already have nice, well-formed adult set of teeth, this is not going to be a problem, right? That calcium's already kind of there for the most part. But people who have developing teeth, namely children, are going to be more affected by this. So you do not use this in kids less than 8 years old, okay? It's a good thing to note. No kids less than 8. You also do not want to give this in the second and third trimester of pregnancy, because this can actually affect skeletal muscle development as well, or skeletal bone development for them as well, okay, for those fetuses. So do not give it to pregnant ladies, especially the second and third trimester. Do not give it in kids less than 8, because we'll have the discoloration and staining of the teeth.
I was going to ask for the drug interactions. What about when they take probiotics? Would it, in any of those?
No, it wouldn't really impede. I mean, if anything, you may find that the antibiotics may kill off some of those probiotics, but you don't really find any kind of interaction from that standpoint. Yep. Again, this is another one that should be renally dose adjusted, so just be aware of that as well. To kind of fitting in that same category is another. Oh, did you have a question? Yeah, go ahead. Probably we will give the macrolide in most of those cases there. The nice thing about azithromycin, anyone familiar with the Z-Pack, pretty easy to take, right? You get 2 pills on the first day, and then you get another single pill on days 2 through 5. It's a good long half-life, so that way you only have to take, 5 days, you're done, right? Whereas other things like doxycycline, you may have to take 7 days, 10 days. You have to take it for a longer period of time because the half-life is shorter. Or you may have to take it more frequently. That's probably the biggest distinction there. Most of the time, you're going to go with the macrolide in most cases there, right? Kind of similar to the tetracyclines is one called tigacycline. I think they called it that based on the fact that it has the 4-ring structure, but it kind of has this little tail here, so it kind of looks like a tiger, right? If you use your imagination, your organic imagination. And actually, all the marketing came at with these tigers. You see this like doctor walking through the halls with like a big tiger next to him, which that was my dream job, to just be like the tiger doctor. But it's actually this bright orange color too, so that's kind of another thing that kind of gives it that tiger sort of branding there. But anyway, so again, this is similar to the other tetracyclines we looked at, very similar coverage here, but this is actually one of those ones that we will save for very resistant sorts of infections. So for instance, we have things like resistant E. faecalis or E. coli. These are going to be good for treatment of that thing. Notice it covers MRSA here as well. So good broad coverage, and you can use it for a lot of like complicated intra-abdominal infections. Just note that it is still bacteriostatic. So if you had a patient who's really, really sick, they have a depressed immune system, again, they may not be able to clear that infection quite as well. So again, we save this one for the most part, but I just mention it here because you may see it used in the ICU occasionally. Again, you can kind of see that orange color associated with that. Kind of get that whole. I don't know if they make it orange based on the whole tiger marketing thing. It'd be interesting to see if they come out with the generic and it's like clear or something. But at least it's orange. So if you ever see IV bags come out and they're like really weird colors, like usually you can kind of link it back to specific drugs. So you ever see like a big red bag? It's like doxorubicin's chemo drug. If you see orange, you think tigacycline. Anyway, the other nice thing about this one is going to be hepatically eliminated, so you don't have to worry about renal dose adjustment, which is kind of a benefit with that one there. Okay, up next we have the aminoglycosides. Now these are going to also be protein synthesis inhibitors, but they are not, they're actually bactericidal. These have very good kill, and the 3 that fit into this category is going to be amikacin, gentamicin, and then tobramycin, okay? Now, these are only going to cover gram negatives, okay? One notable exception is where you use this for synergy along with something like penicillin for enterococcus, but not done frequently. So just know this is going to be most frequently used for gram-negative infections. These are great gram-negative killers, including Pseudomonas, including all kinds of enterogram negatives. Very good for killing this, and actually they retain efficacy even in the face of very resistant bugs. Okay, so they're very good killers with that. And in fact, when you're trying to treat something like Pseudomonas, which is one of those ones that you will actually double cover for, right? It's one of the few ones you double cover for. This is a good component of that, right? So I'm going to use like an aminoglycoside plus something like what? Can you think of any other antipseudomonal drugs? Piperacillin tazobactam, right? So I can try to use those together. That way I have complementary mechanisms to get better kill for that Pseudomonas, right? So something to think about. Anyway, these used to be dosed more frequently, but nowadays we realize we can give it just every 24 hours. And because of that post-antibiotic effect, due to the fact that it's a concentration-dependent killer, which we're now starting to see that, we're going to see that they can be given doses less frequently, get the levels down low, so that way you don't accumulate drug, and that helps to limit a lot of the side effects you're going to see with that, a lot of the toxicity, which we'll look at in a minute here, which namely are going to be the nephrotoxicity and the ototoxicity. So similar to what we saw with vancomycin, if the levels are too high of these drugs, you're going to cause oto and nephrotoxicity. So be aware of that, okay? This is another one we're going to do therapeutic drug monitoring on. So far we've seen with vancomycin, and then all three of the aminoglycosides we're going to do therapeutic drug monitoring on, monitor for levels, okay? Again, just some ideas. Normally when we're looking for levels in this case, notice we're still doing troughs, but we're looking for something different. And actually, in this case, we want to look for low levels. With vancomycin, remember, we want to make sure our levels were high enough to stay above the MIC, but with a concentration-dependent killer now, we're looking for troughs to make sure they're actually undetectable. That tells us that the body's not accumulating it. They're not at risk for developing those side effects, right? Those nephro and the ototoxicity. By giving really big doses, we know the concentration's high because we gave them such a big dose in the first place, but we want to make sure they're actually clearing it effectively. And so oftentimes we'll change how frequently we give it based off that. So if they're not clearing it very well because their kidneys are no good, we give it every 36, every 48. It just depends on how the kidney function is working with that. Another one here we have Zyvox or linazolid. This is a very good backup to vancomycin. So if you had something that it was gram-positive that was resistant to vancomycin, linazolid is kind of your next line agent there. Okay. Now this only has gram-positive coverage. Still is going to be a protein synthesis inhibitor, so we're still kind of in that realm of protein synthesis inhibiting drugs. But this one is going to be only gram-positive coverage, and typically reserve this for patients who cannot tolerate vancomycin or the bugs are resistant to vancomycin. Okay, so that is your backup. Very good for things like community-acquired, hospital-acquired MRSA infections that vancomycin is not good for. The benefit with this one is actually no renal elimination with it. It's all hepatic. So if you had a patient who had really poor kidney function, couldn't really get good levels of vancomycin, or there too much toxicity, you can switch over to this, and they really shouldn't have any problem clearing it, which is the benefit. One thing to note, though, one notable side effect that is unique to this particular drug is that it has an interaction with SSRIs. When I say SSRI, anyone know what that means? Selective serotonin reuptake inhibitor. What do you use those for? Depression, right? Okay, good. So selective uptake inhibitors of serotonin basically increase levels of serotonin in the synapse, right? So you're increasing those levels because you block the recycling of it, basically. So you have more of it in that synaptic cleft. So this drug actually will block the metabolism of serotonin. There's an enzyme called monoamine oxidase. We're going to talk much more about this in the psych section later on. But just know that by inhibiting this enzyme, you're increasing levels of serotonin, right? Not a problem by itself, but if I add this on to something else that increases serotonin, now I'm having the similar problems I ran into with the QT prolongation, right? Once you're adding multiple things that do it at the same time, that's where you can run into problems. So this is where we can develop something called serotonin syndrome, okay? Again, we're going to get into this more in the psych section later on, but just be cognizant of this, where patients who are on Zyvox plus an SSRI, they can be at risk for having the serotonergic toxicity. It can manifest all the way as serious as serotonin syndrome. Okay, so don't get bogged down in that. Just know that's the interaction. We'll talk about the mechanism of that and all the other details of serotonin later on. Okay. Also, the other thing, anything that turns into serotonin. So there's a product called tyramine, which is an amino acid you take in through your diet that can eventually turn into serotonin. That is also going to be interaction as well. Tyramine-containing foods usually includes a lot of, I always call them like the bougie foods. So there's going to be things like aged cheeses and aged meats and red wine and all sorts of things that have a lot of tyramine. They get converted over into serotonin eventually. And so when you block that metabolism, so again, you have more coming in, and then you're blocking the metabolism, that can also lead to that serotonin toxicity. Okay. So again, probably not for your fancy patients that are out there going to nice dinner parties. They're going to have a lot of tyramine in their diet, right? Okay. Anyway, I'm out of time. I wish I was done with this. I'm gonna. You'll have a quiz next week, I believe. Is that correct? Looking at your schedule, so it'll only cover sections 1 and 2 up through what we've covered today. So I'm going to modify that so it'll make sure we don't include things we have not covered yet. Again, I'm trying to get through all this stuff as quickly as I can, but there's a lot to it. And again, you're going to use these for the rest of your career, right? So again, these are good drugs to know. And then we will have the test, which I think is like 2 weeks after that, something like that. I turned the test in already to Professor Murray, so that's all good to go. And then your assignment is due. That's been posted, right? Again, on the assignment, I will count off for things that are not there or things are obviously wrong. If it's the style thing, I don't count off for that, right? I can give you some feedback on that though and say, hey, I might have written it like this instead, or I might do this instead. So don't sweat the details quite so much. Just make sure things make sense, right? Make sure that if you write for so many of our tablets a day, make sure that your quantity to dispense matches that, right? Or make sure that the bottle sizes are big enough to fit, what you're actually going to be administering to that patient over that time frame. Those are things to think about, okay? Any questions before I let you guys go? Nothing? Everyone's head spinning? Yeah, so for the quiz next week, I will not have fluoroquinolines on there. It'll probably just be a paper handout. It'll be probably, a small set of multiple choice questions. That way you can at least start to get an idea for, what type of questions I might ask on a test. Maybe some math. I don't know. I'll figure something out, right? It will not be too bad. Because again, I don't stress you guys out too bad. But it'll be quick. We'll do it in the beginning of class, and then we'll turn it in, and I'll grade those later. Let's do 10. 10 question quiz.
And then as far as the exam, it's really kind of like behind the schedule. Does that mean like all the same stuff like opto, derm, and UAT?
Yeah, so when it says units 1 through 4, that's all the stuff it's going to cover on that exam there. Yep. And that would just be a 50 choice, or not 50 choice, 50 question multiple choice, 5 answers. You have 1 question, but 50 choices. Good luck. Hope your guessing game is on point. You have a 2 in 100 chance of actually guessing it correct if you do that. Any other questions I can answer for you? If not, please feel free to email me. If you have any questions come up about this, yes, ma'am.
For the one that says signature with appropriate credentials.
Okay.
For 10 that were PAC.
If you write PAC, I'm not going to count off. If you write PAS1, I'm not going to count off. That doesn't really matter. If you were writing it from the guise of a fake physician you made up, and you write MD, that's fine. Whatever. I don't really care. I just want some kind of credentials there to show you at least thought about it and you put it down. Okay. Okay. All right. I'll see you guys next week.